Good morning, everyone. Hi, Karanvinu. How are you?
Hi, good morning, Shweta. How are you?
All good. Good to see you after a long time.
Life is too busy to see each other. We have been contributing here and there.
Yes.
Good morning, everyone.
Hi, good morning.
Good morning.
Yeah.
You're
Um,
joining, you're joining
yes.
from?
I'm Pier1 from Thailand.
Oh, wonderful. Welcome.
Welcome, welcome.
You'll not believe how many registrations we had. More than
I am pleasantly shocked, I would say.
yes, it is. It's a movement.
2,500, 600. Hi, Parag, how are you?
Good morning.
Hi, good morning, Dr.
All,
Parag. How are
See
you?
you?
all set?
I guess so.
Yes, so.
Okay, I'm
Hi,
just in the
Krishna.
practice
I
session.
don't happen to have met you.
Yeah, I know, Colonel. I'm just in a practice session. I'm going to rejoin only at 11:15 when we have our this thing. I
But
have another parallel session going on.
ours is the first one, starting 10 o'clock.
Yes. See you, Dr. Parag.
Sure.
Sure.
Good morning and congratulations to CAHO on the number of people registered for this.
It's a
Absolutely.
super fantastic number,
Historical figure.
historical figure. That speaks of the passion for safety and passion for CAHO.
Absolutely.
Both.
Absolutely. Agreed. We have Dr. Anuradha. Hi, Dr. Anuradha.
Is she?
Yeah, she's joined, but
Okay. But
I can see Aparna is also there.
yeah, there are a lot of people. It's traveling.
Yeah.
Hi,
Hi.
Anuradha.
Okay.
She's always on the go.
Hi, Tushar. How are you?
I am good, Sweta, Dr. Sweta. Good morning.
Good morning. Safe travel, Dr. Anuradha, and lovely of you to join.
Ma'am, shall we start the webinar with the CAHO anthem?
Yes, I think we should start on time.
Yeah.
A new dawn, a new horizon of healthcare delivery and patient safety. We have a goal, a noble drive.
Hand in hand, step by step, we will thrive.
To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion. Standing right by your side. Joining hands for building a vision, shaping a culture for patient safety.
Setting up standards with best foot forward. Won't ever leave no stone unturned.
We wear our pride on our sleeves, walk with passion like a breeze, training people, enhancing their skills, spreading the message of quality healthcare for safer patient care, a better nation.
We have a goal,
We have a goal,
a noble drive.
noble drive. Hand in hand, step by step, we will thrive. To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion, standing right by your side.
So, I think good morning, everybody. I'm Dr. Aparna Jairam. On behalf of CAHO family, CAHO team, we welcome everybody here, and I think it's a immense pleasure on behalf of our whole team to have so many panelists and also wonderful response for the participation, as we all can see. We really would like to, without any further ado, start our inaugural program. So if, I have Dr. Piyavan here. So over to you, Doctor, to give the inaugural address. Thank you.
Good morning, everyone. It is an absolute honor to be here with all of you today as we come together to celebrate World Patient Safety Day, a day that shines a spotlight on one of the most fundamental aspects of healthcare, the safety of our patients. I would like to extend my heartfelt thanks to the CAHO for organizing this important event and bringing us together, even virtually, in the shared pursuit of shared care, of safer care. Today's theme, Improving Diagnosis for Patient Safety, and our powerful slogan, Get It Right, Make It Safe, reflect our collective mission to ensure that every diagnosis we make is accurate, timely, and rooted in the best practice of patient care. It is a mission that affects every one of us in healthcare, from clinicians and nurses to diagnosticians, quality professionals, and healthcare readers. Diagnosis is the foundation of patient care. It is the first step on the path to healing. Yet, we know that diagnostic errors are one of the leading causes of preventable harm in healthcare. When a diagnosis is wrong or delayed, the entire course of treatment is compromised, and behind every error is a patient, a human being who may face unnecessary pain, suffering, or even loss of life. Globally, it is estimated that 10 to 15% of diagnoses are either incorrect or delayed. As statistics that represent millions of people affected by errors that are, in many cases, preventable. Getting it right is not just a goal, it is a moral imperative. This mission to get it right, make it safe, is not the responsibility of one individual, one professional, or one department. It requires the coordinated efforts of every healthcare professional. To the clinician in this virtual room, you are at the front floor of diagnosis. Your ability to think critically, ask the right questions, and apply your knowledge directly affect the life of the patients. You hold the key to ensuring that every patient's journey begins with an accurate diagnosis. To the nurse, you are the backbone of patient care. You are often the first to notice subtle change in the patient's condition and the first to raise concern when something doesn't seem right. Your role in the diagnostic process is invaluable. To the diagnosticians, radiologists, and lab professionals, your precision and attention to detail provide the data that guides every clinician decision. Without your work, accurate diagnosis would be impossible. To the quality professionals and healthcare administrators, you are the architects of the system that ensure diagnosis safety. Your leadership and commitment to continued improvement make our healthcare environments safer for both patients and providers. Improving diagnosis is a complex challenge, one that involves not only clinician experts, but also system design, communication, and technology. We face many hurdles from cognitive bias that good judgment, to fragmented communication between teams, to limited access to diagnostic tools in certain settings. But these challenges are also opportunities for innovations. Advances in AI, machine learning, and big data are opening new doors to diagnosis medicine. These technologies are helping us recognize patterns that were once invisible and are assessing clinicians is making more informed, data-driven decisions. However, while technology can enhance our work, it's no substitute for the human element, the critical thinking, compassion, and collaboration that drive accurate diagnosis. Today's virtual gathering providing an incredible opportunity to exchange ideas, share best practice, and learn from each other. By working together, we can identify new ways to improve diagnostic process, reduce errors, and ultimately make patient care safer. In healthcare, diagnosis is a team effort. It is not responsibility of one individual or department, but a collaborative process that relies on open communication and shared responsibility, from the bedside to the lab and from the radiology to quality management. We must also engage our patients as a partner in their care, involving them in the diagnosis process. And we must build a culture where every voice is heard and every concern is taken seriously. Our slogan today, get it right, make it safe, is not just a reminder of what we strive to achieve. It is a call to action. I encourage you all to think about how we can turn this word into action. How can we leverage technology and innovation? How can we improve communication and collaboration across teams? How can we learn from our mistakes and create systems that reduce the likelihood of diagnostic errors? And most importantly, how can we ensure that every patient receives the accurate, timely, and safe diagnosis they deserve? The future of patient safety depends on our ability to improve diagnosis. It is a future where every diagnosis is correct, where every patient receives the care they need, and where safety is embedded in every step of the diagnosis process. Let us commit today to making this vision a reality. Let us work together to ensure that getting it right is not just a goal, but a guarantee that making it safe is the standard by which all healthcare is delivered. With great anticipation and pride, I now declare this program officially opened. Let's today discussions, collaboration, just my organization with CAHO and innovation guide us toward a future of safer, more accurate diagnosis for all. Thank you, and I wish you a productive and inspiring World Patient Safety Day for improving diagnosis together. Thank you.
Dr. Piyavan, it's amazing to have you as the Healthcare Accreditation Institute CEO and taking out the time for us to share your thoughts. And this is very, very dear to us as laboratorians because the theme itself is improving diagnosis for patient safety and get it right and make it safe. I welcome all of you again, those who have joined in the transit. All my CAHO family, team, and delegates. As I think we have to move ahead, we have the blessings of our patrons in this program. Everybody knows Dr. Girdhar Gyani. He is. I don't think he's able to join us today. He's in another program in Delhi for the same. Thank you, sir, for guiding us in planning this program. We have, next slide, Ravina. We have our founder, President CAHO and AHPI, Dr. Alexander Thomas, always there. When I started planning this program, I was discussing, and I think the way we have got our panelists and the response says it all. Thank you, sir. The next slide. We have Dr. Pawan Kapoor, who has been instrumental again in getting me with Shweta and Parag to make this program in such a way that we get the nursing, we get the biomedical engineering. You will see how it is going to come up. We also have cyber security. So I think these are the people who have really guided me to conceptualize the whole program. Thank you, sir. The next slide. Everybody knows him. He is the guiding force for all of us, Dr. Vijay Agarwal. He'll be joining our our celebrations very soon. President CAHO. The next slide. She is the Secretary General. Everybody knows again, a very, very, what do you call, the face of the leading force for CAHO. And she is Dr. Lalu Joseph. The next slide. We have Dr. Shankar Sen, who is the Vice President CAHO. Again, a very, very a good laboratorian and a microbiologist. So he has been very instrumental in spanning out this program. Without further ado, I think we go ahead. We are a little ahead in time, but I think it's better to be in time rather than because panel discussions may take slightly more time, but I request the moderators to address the issues, and we have, I think, 10 minutes to 15 minutes extra, but we begin the panel discussion. And thank you, Dr. Piyavan, to be there and start the program for panel discussion, communication issues, effective communication. So all the very best for our first panel discussion. Our moderators are Father Johnson, again, ED and CEO of Rajagiri, but more than that, he was one of the key persons when we actually started this along with Naren sir. Both of them, we had a call 2 days back again, how to conceptualize, how to stick to the time and get the right answers so that we get it right and make it safe. So one of our moderator is Father Johnson. We have Dr. Naren Sehgal, who is medical director at Sehgal Neo Hospital, but he's our finance secretary for CAHO. So welcome, Dr. Naren Sehgal, sir. It's over to both of you to conduct the first panel discussion of communication issues and how effective communication is important for the safety of patient. Over to you, sir.
Thank you, Aparna. Thank you, Aparna and CAHO, who have taken this opportunity on the World Patient Safety Day and are trying to communicate such an important topic, I think, which has been taken up by WHO also this time, of patient safety. And it is really heartening to see that 519 participants are already there in this panel discussion. And from what I know, I think 27 or 2800 delegates have registered for this, and we would be seeing the number increasing every minute, I hope. So thank you so much. Let's begin the proceedings. And on this CAHO Patient Safety Day, which is actually on 17th of September, we are celebrating today for convenience reason. It was declared by WHO, and orange color as a glow across the globe to highlight the importance of correct and timely diagnosis. Timely diagnosis and correct diagnosis are two important aspects which should be there, because the hero of our whole act is a patient. And unless and until we put into consideration everything for the safety of the patient and the quality which we deliver to them, which then otherwise we will not be able to accomplish our task. And for this, I thank CAHO again, because they are the basically people who have been taking and bearing this torch, lighting this torch and taking it forward for years now. The theme this time is improving diagnosis for patient safety, and the slogan is get it right, make it safe. It is an opportunity to raise public awareness and foster collaboration between patients, health workers, policymakers, and healthcare leaders to improve patient safety. And today, in this panel, we are going to speak about the communication issues, basically effective communication in healthcare. And I am one of your panelists, as Aparna has already introduced. I run a hospital, and that's why basically a lot of these things from patients perspective are, very well known to me, because I've been doing this for last 35 years. And with me, I have Father Johnson. Sir, if you will just say hello and introduce yourself.
Hello, good morning, everyone. I am Father Johnson. Thank you, Dr. Abarna, for the great effort that you are putting in and organizing such a big event. I think an introduction from Abarna was very accurate. Maybe what is missing is CAHO is a body where there are many verticals, and I am chairing the Healthcare Institution Division. And I am in Cochin, Kerala, extreme south of India. The name of the hospital is Rajagiri, and I am the executive director and CEO of this hospital. So over to Dr. Naren.
Thank you, Father Johnson. See, about this topic, the effective communication in healthcare, I think probably till a few years back, it was realized, people used to realize, but probably there wasn't any mention about communication. There were no teachings and there were no trainings. But now it has attained such an importance among all of us that we realize that good communication in healthcare is as important as the treatment we give. It helps patients understand their health, follow their care plans, and feel more comfortable in a stressed environment. However, when communication breaks, it can lead to confusion, mistakes, and even harm to patients. So that is why this becomes a very, very important topic. I will not discuss much on this. We will take this from the views of our panelists. But before that, I'll just like to give you one example what I have realized in last few years, that how bad communication, ineffective communication can lead to problems. See, I am a surgeon, and 25% of the practice of any surgeon is anorectal problems. And a simple thing like sitz bath. A sitz bath had been ordered by a surgeon. It was not explained to the patient what it means. Simple order was sitz bath with betadine in lukewarm water. Now, this patient came to me after 1 month of treatment and said, I am not getting better. When I tried to understand everything from the patient, that what the patient was doing, that even 1 month of treatment has not improved him, I came to know he had put betadine in his lukewarm water and he was taking a bath with it. So that's the kind of, simple, not giving proper instruction. This is what can it lead to. Second example was a general practitioner had written sitz bath in potassium permanganate. This patient came to me with severe burns on the buttocks, because this patient was explained that you have to sit in the tub with lukewarm water with potassium permanganate in it, but nobody had instructed, or he had not instructed, that you have to just put a pinch of potassium permanganate and not a whole lot of potassium permanganate in it. So see the harm it can cause to the patient. And now let me introduce our panelists. I would request Father Johnson to introduce some of them. We have 6 panelists with us. Father Johnson, sir.
Yeah, again, welcome. I'm greatly honored and privileged to introduce Dr. Deepak Patkar, then Dr. Neil Sekeura, and Colonel Binu Sharma. Dr. Deepak Patkar is the Director Medical Services and Head Department of Imaging, Nanavati Max Super Speciality Hospital, Mumbai. He has 36 years of experience as a radiologist with a demonstrated history of working in the outsourcing or offshoring industry, skilled in MRI, clinical research, medical education, medical devices, and medicine, a strong consulting professional with a Doctor of Medicine, DMRD, DMRE, FICR, focused in radiology from Mumbai University, Mumbai. So welcome Dr. Deepak Padkar. And the second panelist, Dr. Neil Sequeira, currently the Chief Operating Officer at Thane Cancer Hospital. Experienced professional and psychologist with a demonstrated history of working in the hospital and healthcare industry, strong human resource professional, skilled in management, business development, organizational development, recruiting and training, been formerly worked as Chief Operating Officer, Head and Neck Cancer Institute of India, Mumbai, Maharashtra. Also was the Vice President, HR and Administration, Kogilaben Dhirubhai Ambani. Also served as the Director, Human Resources, Hinduja Hospital, and Head HR, ISS Integrated Facility Services. So welcome, Dr. Neil Sequeira.
Thank you. Thank you very much, sir.
Colonel Binu Sharma, currently the Senior Director Nursing, Max Healthcare, President INS India, US affiliate. 4 decades of experience in the healthcare field. Experienced Vice President of Services with a demonstrated history of working in the hospital and healthcare industry. Strong business development professional, skilled in healthcare consulting, medical devices, healthcare information technology, critical care nursing, and healthcare management. Served former as the Senior Vice President, Nursing Service, Columbia Asia Hospital Private Limited, Chief Nursing Officer, Max Healthcare, and also, interesting to hear that Lieutenant Colonel was in with Indian Army. So welcome Colonel Binu Sharma to this panel discussion.
Thank you, sir.
Over to Dr. Narendra.
Thank you, Father Johnson. Let me introduce rest of our esteemed panelists. Dr. Sanjay Arora, who's a pathologist by profession, and basically he was founder of Suburban Diagnostics, which he ultimately exited, and now he's a founding partner of Shubhan Ventures. And it is known about him that from being a pathologist, now he is everywhere giving lectures, educating, and traveling, photography, and TEDx speaker. Welcome, Dr. Sanjay Arora.
Good morning, Ji. Good morning.
Dr. Rajendra Patankar, he was CEO at Nanavati Super Speciality Hospital, Mumbai, and has now been appointed and has been working since 2019 as a CEO of Jupiter Hospital, Pune. His experience provided great value in providing strategic directions and vision to the hospital, and a focus on clinical excellence and patient centricity remains very important with him. Welcome, Dr. Rajendra Patankar.
Namaskar.
And Dr. Nilesh Shah, welcome, sir. We were together in a panel discussion on Smart Hospital 2 days back in Delhi. So welcome again. And Dr. Nilesh Shah, who is basically an advisor and CEO at Metropolis Healthcare. He has been associated with Metropolis for last 36 years. That's what I believe. So welcome again, Dr. Nilesh Shah.
Thank you so much.
So starting the panel discussion, let me put this first question to Dr. Sanjay Arora. Sir, I have heard about your journey of starting from one lab to 250 labs in 16 cities. And now, as I already said, you're a teacher, guru, traveler, TEDx speaker. With a background of such a wide and vast experience, how will you define effective communication, especially in relation to healthcare and its importance?
Thank you, Dr. Sehgal, for the very warm introduction. Thank you, Aparna, for inviting me to be a part of this illustrious group of people, great set of people. Thank you for that. You know, I receive calls from patients every day today. I always tell people that medicine is like a black box, and there's not enough information available for patients on what's the best way to consume healthcare. And I think the objective of this panel today, or at least for me, has been to demystify healthcare, is to make decision-making in healthcare more streamlined and accessible for patients to take the right decisions. I think there's you know, for people like me, you know, Aparna, Dr. Suvin, Dr. Nilesh, who've been, and of course, Dr. Deepak Patkar, who've been part of the diagnostic industry, I think we are in a privileged position that almost all specialities have to go through us and all patients have to get connected to us. So we're at a very unique vantage point that we can actually connect both sides of the medical ecosystem and the patient ecosystem. And I think over the last 30 years, that's what I've tried to do, is to try and demystify healthcare so that patients find it easy to understand what is required and what is not, to try and make them aware of you know, the pros and cons of the choices that they have. And I think essential communication becomes critical in that. When you have very busy consultants, and not to take anything away from them, I think they may not have the adequate amount of time to give and, you know, explain why a particular investigation is required, why a particular drug is given, why these tests are done, what's the root cause. Maybe diagnostics, you know, people have a little more time available at our hands. So we've been able to give them that kind of quality of time to explain the why, what, and how of healthcare. And I think that's probably been my journey over the last 30 plus years of being in healthcare, is to try and demystify, is to bring communication in a simpler manner so that patients find it easy to take decisions in healthcare. I hope that helps.
Definitely, Dr. Sanjay. I think I can definitely say in the last couple of years, I have seen this transition of, you know, concentrating only on disease, from concentrating only on disease to patient. I think patient-centric is what is required, and we are very effectively moving towards that. That's wonderful. Father Johnson.
Yeah, again, Dr. Deepak, good morning.
Good morning.
Yeah, we are all amazed to hear that, you know, you have many decades of experience in healthcare industry, and specifically into radio imaging. So glad you should be having a lot of points to share with us so that the issues in communication can be made better, you know, for our patients.
Yes, sir.
So I have a very small question, limiting to the radio imaging sector alone. So what are the key areas of focus for ensuring effective communication in radiology?
Good morning, sir, and thank you everyone from the panel, and especially Dr. Agrawal, Lalu, and Aparna for inviting. Like Sanjay said, pathology and radiology today are kind of eye of every part of medicine. Without pathology and radiology, there is just nothing happens. Say 25, 30 years back, clinicians before CT, MRI came in depended very heavily on their sixth sense. Today, because of medical legal issues, costs involved, without radiology and pathology, no diagnosis is made. The major issue that we face as radiologists starts from patient in terms of patient preparation, education. The other major area that we face effectively every day is communication between radiologists and the referring physicians. The third is interdepartmental and intra-departmental coordination. In a large department like ours, where 450 patients we have to attend every day and 15, 20 radiologists working continuously, it is virtually impossible to keep communicating continuously. The fourth challenge that we face is timely and accurate reporting of critical results, whether it is pneumothorax, whether it is ruptured appendix, whether it is twisted ovary, whether it is hyperacute stroke. Communicating between radiologists and communicating between the radiologists and clinicians is a very, very big challenge. The other challenge that we face is patient follow-up and monitoring. We say something, the clinician says something else, and the patient gets confused as to when the scan needs to be repeated. What are the limitations of imaging? People don't understand. They think this is like a last word and we have to give histopathological diagnosis. That's not possible everywhere. Sixth thing is cross-training and interdisciplinary coordination and collaboration. So we talk about MDTs, especially for cancer patients. A radiologist, radiation oncologist, medical oncologist, and surgeon have to sit together and plan one thing for the patient. You can't plan four things for the patient. All this requires a lot of patient-centered communication, and that's where all of us have to work continuously towards getting better. In terms of preparation, we need to know whether the patient needs to be fasting, creatinine is required or not, metal demetallization has to be done or not. It starts from there. I remember people calling me at 11:30 in the night, ki pani pi ke aana hai ki nahi, bypass hua hai to kar sakte hai ki nahi. It starts from there. So clear pre-procedure instruction is the need of hour. Visual aids and resources are there. Post-procedure care is equally important, especially after PET-CT, that they have to be away for 4-5 hours from pregnant ladies, etc. In terms of challenges in communication between referring physicians and us, the physician many times does not know what is the ideal investigation that is required, whether CT or MRI, whether ultrasound is good enough, the amount of radiation that the patient is going to get, etc. So that communication is important. In terms of interdepartmental coordination, again, the differentiating supra-urgent scan from urgent scan and a routine scan is a big challenge. For every patient and every physician that the patient is referred to, everything is emergency. So differentiating that is a critical issue. We follow American College of Radiology guidelines for that, but everybody does not very clearly accept it. MDT is another area where very, very important communication and decision-making happens. So these are about 6 or 7 areas that we have to work on, and there are way forwards always. Thank you.
Yeah, thank you, Dr. Deepak. When I heard the expressions like coordination, collaboration, a lot of memories coming to my mind. Always radiologists talking their issues with regard to the consultants. What is consultant is written, radiologists say that it's not completely elaborated. So that brings a lot of, we will come back to you again to this topic. So thank you so much for that valid insights. Over to Dr. Naren.
Thank you, Father Johnson. Now, coming to you, Dr. Rajendra Patankar. From what I know, you have a vast experience, long experience, first as a CEO and now as a CEO of Jupiter Hospital at Pune at present. During these many years, you would have managed thousands of doctors, nurses, and rest of the staff, along with managing the hospital also. Can you please share your experience of handling this manpower? How much does communication play a role in this?
Yeah. So good morning to all of you. Good morning to my fellow panelists. Thank you, Dr. Aparna. Thank you, CAHO team. Thank you, Lalu. Thank you, Dr. Agarwal, for inviting me for this event. It's a pleasure to be here today on the occasion of this World Patient Safety Day. As someone who has spent almost more than 2 decades now in hospital management, I have learned a lot about handling HR, staff, doctors, and the business side of healthcare. But this is not about process, which is normally what we hear every time. It is also, and more importantly, also about people. And I always feel that people are the backbone for any hospital, or for that matter, any organization. I mean, our nurses, the support staff, the admin staff, these are the first point of contact when a patient comes to the hospital. He doesn't come and directly see a doctor. He comes and sees the other people in the organization. And, right from there, communication becomes very, very key. And, that's why regular training, creating a good healthy working environment is something what we need to do as administrators. People should feel valued and heard. Only then they can give their 100%. Jupiter Hospital, we have done some significant improvement in the staff morale, in patient outcomes as well, when we started something called as the feedback sessions. Not only as a part of me or the senior management team, I've also involved the nursing managers, the team leaders level as well, to have small hurdles or urge them to actually call up their team in the morning for a few minutes and brief them, and let an open channel of communication be there between them. And that, in my opinion, has worked a lot for us and in my past as well. Earlier people did not report incidences, and reporting of incident reports were very few. Now, with an open culture, near misses, incident reports are getting captured, and then they collaborate together to do a corrective and preventive action, or CAPA. And this is all because we need to have a seamless two-way communication between our staff and the administration. Unless the team feels supported, they cannot perform better. And if you support them, they will certainly overwhelmingly actually help you in the whole process of healthcare delivery. Coming to doctors, one should understand that they are not just professionals, but they are our partners or pillars in our organization. I mean, without them, you can't deliver healthcare. They are an important part and parcel of the whole healthcare delivery process. For that, I feel an open communication between doctors and administration is a key. And I've always practiced the open door policy. Dr. Deepak Patkar is here on the panel, and he will vouch because I was with Nanavati Hospital earlier, and we worked together so clearly that it could help to turn around the entire hospital. And it's very, very important to ensure that the lines of communication with doctors are clean and clear. Apart from the regular meetings or mortality review meetings and so many other clinical audits and clinical meetings that you conduct, you should also have a one-on-one feedback with doctors, so that they can voice their concerns, share their suggestions, and they also feel involved in the whole decision-making process. Because unless you make them a part of the whole activity itself, their involvement gets reduced. And this is something which I've found in many places, where there's a deficit between the management and the consultants. And as hospital leaders or healthcare administrators, it should be our role to ensure that this gap is bridged as much as possible. A simple thing like starting a WhatsApp group of your own consultants and letting them actually raise their concerns, voice their concerns, or address their requirements on the WhatsApp group itself can go a long way. It helps to bridge the trust deficit that sometimes is there. And this is something which we did, and I have done in my career for last 2 decades. But I also feel that, any communication between your staff and management has to be a two-way street. You can't just keep on passing orders and then expect them to only listen. You have to listen to them as well. So unless it's a collaborative approach, you can't really excel in what you intend to achieve. Coming back to business, because I have to also hold the P&L responsibility. It's difficult to run a hospital efficiently with quality. Sometimes people don't realize that quality carries a certain amount of cost, and we cannot compromise on patient safety or quality, and it's a balancing act for that matter. Cost cutting can't come at the expense of safety and quality. Instead, we should focus on cost optimization. Cost cutting, in fact, is not a good word at all. So the better word to use is cost optimization. And all administrators have to play a big role to ensure that we have to navigate through those small violins to ensure that we are EBITDA positive as well as we are quality positive also. Here, I would say that technology plays a very big role. And if you have a good, robust HMI system, EMR system, then it helps you a lot. Otherwise, you'll find a lot of nurses spend more time on their computers in the nursing table than onto the patient's bedside. And this is something which technology can really address. I mean, small, simple things where if the HMI system can auto-post certain entries or create certain templates for nursing staff, it goes a long way to reduce their time spent on just entering data. And that time can actually be spent on the patient's bedside, which ultimately will result in good patient care and minimization of errors. And that is ultimately the whole objective of us as healthcare professionals. Another area which I feel as administrators holding P&L responsibilities is to ensure that we have an energy efficient infrastructure. I am glad to share that at Jupiter Hospital, Pune, we are an energy efficient building certified by a Swedish agency. And it has helped me substantially reduce my power cost. And as you know, power is one of the big ticket items on my expense sheet of the P&L account, apart from the manpower cost. So having a good sustainable system where you have good infrastructure to ensure that your operating expenses are optimized goes a long way. Post the pandemic, we have realized that crisis can hit you anytime. Pandemic may hit once in 100 years, but there are so many things which keep on happening in the hospital, and you need to have robust protocols in place. Training of our staff to handle emergencies should always be continuously as a process, and these are non-negotiable things that we must keep in mind always. So, I mean, for that matter, I'm sure most of the accredited hospitals, thanks to NABH, they have to undergo certain defined audits and defined regular drills, whether it's code blue, code orange, code white, all of them. And it is something which really helps us to keep us on our toes. I mean, you can't be reactive. You have to be proactive now. And by being proactive, you can save not just money, but also lives. And that is something as healthcare administrators holding quality and patient safety, it will help us to take us to the next level. I mean, I genuinely feel that it is not about ticking boxes. It is about ensuring that every element of the whole ecosystem, human ecosystem, whether it is HR, whether it is the staff doctors, the technical staff, or even your administrators. It's like conducting an orchestra, so to say. Everybody is important. Everybody has to play their role independently and together in addition. किसी एक का भी अगर सुर खराब हो गया तो पूरे गाने का मजा निकल जाता है. So it is very important that as leaders, we have to ensure that everyone plays in harmony, and that's the whole objective of us as administrators, to ensure patient safety while giving high quality patient care at the same time. So, I mean, these are my thoughts. Thank you.
Wonderful, Dr. Patankar. Excellent. I think feedback is so important, I think, because what happens whenever you're doing something, any kind of job, you probably remain in a zone where you believe, yes, this is perfect. I'm doing everything right, and everybody should be happy and satisfied with this. But it is only the feedbacks which really give you insight into how the processes are running. Are they effective enough? Thank you, Dr. Patankar. Very well said. Over to you, Father Johnson.
Yeah, Dr. Neil Sekura, again, welcome to this panel discussion.
Thank you.
This is an area, age where we focus so much on efficient use of, resources. Because, you have all the scheme patients, Ayushman Bharat, capping from the insurance scheme. So we have to efficiently use the resources. And in the resource category, manpower, HR, it's one of the important segment. Since you are a veteran in the field of operations in the healthcare settings, our question is, how do you relate the mental health of the staff and the effective communication, or the right way of communication?
Okay. Am I audible, sir?
Yeah, very much.
So it's always a pleasure to listen to Dr. Rajendra Patankar. He just gave us a crash course on how to build a hospital and run it. It was the shortest tutorial. Thank you very much for having me, and it's a pleasure and an honor. Dr. Sanjay, I'm seeing you after a long time. Dr. Arora, every time I look at you, you seem to glow all the more. And Father Johnson, I've heard so many things about you every time I go and speak at CAHO meets. Someday I hope to actually come down to Rajagiri. God bless you. Do keep doing the good work of the Lord.
Yeah, you are always welcome.
So I know, to answer your question, sir, I'll tell you a story of Angeline. Angeline is a nurse. She's around 34 years old, lives at a place called Vasai in the outskirts of Mumbai, works at a multi-speciality tertiary care hospital in the accident and emergency department. She's got two kids, a boy who's in the 9th standard. She's worried about the 10th standard, a girl who's in the 6th standard. Her duty times are 8 o'clock in the morning, for which she leaves at around 6 o'clock. Before that, she's got to cook the tiffins of her two children, also make chapatis and vegetable for her husband, who's a vegetarian. She does all that and enters a crowded train in Mumbai and somehow makes it to her duty at 8 o'clock in the morning. She's worried as she's traveling. She's worried about various issues that are cropping up in the family. A mother-in-law who constantly nags her, and she reaches the accident and emergency department. When she enters the department is busy as usual. There is a mob of people because a local politician has been stabbed. There are other cases where there is a stroke patient, there's a patient having acute MI. And she's supposed to actually go and, talk to all of them, show compassion, take care of them, couple of irate relatives, etc. She does this the entire day, my friends. She does this the entire day. The scenario, the patients keep on changing. She wants to go for lunch, but she hardly gets 10 minutes to do that. And just as she's preparing to finish her day off, because she's got to go back and take the lessons of her son, who's got an exam the next day, her in charge calls her up and says that her reliever is not come and she will have to do an additional duty. She does some frantic calls for arranging for the children, calls up her husband, and then, she begins her next duty. And by this time, she's slightly a different person. She's a little irritated, she's a little angry, the lack of compassion goes down, shows total lack of compassion. What we see here is something that we call as compassion fatigue. And this continuously keeps on happening to so many healthcare workers around. It is compelled and it is complicated by the fact of extreme shortage of good resource and manpower, the demand and supply economics of manpower in our country. And it becomes very difficult for us to expect compassion and expect, good care. I'm not even talking about the quality of service going down technically. I'm just talking about the psychological aspect. So then, how do you actually mitigate this? Compassion fatigue can be mitigated by something called as compassion satisfaction. And you know where this comes from, friends? This comes from the communication that people have with you. Compassion satisfaction is generated from a patient or a patient relative, probably going back to Angeline and saying, thank you for all that you've done for us. Going and appreciating the fact that she was able to save a life. It comes from her departmental head, who will probably at the end of the day sit with her, talk to her and tell her that, you know what, you're doing a good job. It will come from the organization, who will probably recognize and give her credit for all the work that she's been doing silently. And mind you, Angeline is one of the 600 nurses in the system. Organizations need to have a continuous process of actually communicating to their staff. Leaders need to have, and that will take care of primarily mental health issues. Many a times our staff feel angry, frustrated, and they get upset because there is no communication. The leader expects that by leadership, I mean, we look at our families. You know, we expect our spouses, we expect our children, we expect our parents to know how much we love them. We never express it verbally. We say, so what? And they know I. It's very important for human beings to actually express and listen. So how do you manage and create more compassion? You know, communication is not only with the others, it's important to actually have some me time also. I need to communicate to myself. And it's only when I communicate to myself, that is my me time, in that part of the day, in prayer, in reflection, in talking to myself, in talking to anybody, which helps me make me a better person and a better professional. Be around with positive people. Be always positive to your subordinates. Be always positive and stay away from negativity. I always tell, you know, as a psychologist, I always tell people, please stay away from negativity. If reading the political news of the country causes you anguish, try to avoid it as much as possible, because there's a beautiful prayer, you know, we call it Saint Francis's prayer. It says, God grant me the serenity to change things I can change, to accept things that I cannot change, and most important of all, to know the wisdom, the wisdom to know the difference. Thank you, sir.
Oh, Dr. Neil, very, very inspiring. I wish if you got more time to speak on that. I think you're an excellent speaker. A lot of insights and inspiration all the way through. Yeah, we will come back to you. Thank you, Dr. Neil. Over to Dr. Naren.
Thank you, Father Johnson. Fantastic, Neil. I think what we need to learn is that we have to start thinking beyond ourselves, because most of us, we are so busy with our jobs that probably we don't have much time to think of our surroundings, people who are working with us, and we only think all about ourselves. But from what you are telling me, if little compassion, little consideration of your surroundings is kept into your mind, it will definitely improve our working environment very much. Thank you so much. And now coming to Dr. Nilesh. Nilesh, I was talking to Aparna, and I found out, because I didn't know your background of that long back, that she told me that you were known as a person that in 1999 in a place in Bombay, probably, when you were running Metropolis, people have seen patients coming to you shouting, angry, and everything. And you used to deal with them, and they used to go back smiling and thanking you with a box of sweets. I really wonder how you could achieve all this. Can you please touch points with us to increase our knowledge with this gift of yours? How did you do it?
Thank you so much, Dr. Naren, and thanks, Dr. Aparna, for reminding all this. And those are all pleasant memory which keeps me motivating. I think this is a subject of communication, and I want to talk about communication in challenging time. I believe as a laboratorian for 40 years, you stay backend, you run the test, do good work. It doesn't get recognized and acknowledged as much when you speak about it with all honesty, no manipulation, all honesty. And the best time to prove your worth is when you get challenged. When your report gets challenged, your result gets challenged, your service gets somewhere criticized, that's the best time where you can prove yourself. I take this as an opportunity. In our field, I think when we were recruiting any doctors or any front-end staff, communication used to be very important. Let me talk about doctor. A good doctor with good knowledge and everything is important, but equally important is his good communication skill. In our field, I would say a right report given wrongly will be perceived wrong, and a wrong report given rightly will be perceived right. And that's the art. You don't manipulate, but you can actually make people comfortable with all honesty if your communication is right. I am never saying do any jhol, do not manipulate anything, and honesty is extremely important. So the cases which you remind me, I think I would like to say 2-3 areas there as a tip. This has been one of the class which I should take in IIM Ahmedabad on this subject for 1.5 hours. I'm going to say in very, very short time. I think the time has gone where we work only for customer satisfaction. The time has also gone where we have raised bar and we said, I want to create customer delight. Time has come where we create customer obsession. Obsession to a level that he cannot do a test without you. He cannot work without your service. That obsession we have to aim for. Automatically, you will find your own path. There is no book or anything to refer and make this happen. But your all honest approach, this is my goal, and work towards it. And specifically in challenging time, where somebody is in pain, somebody in trouble, somebody is upset, your result has not come on right. If somebody else has given different result and all, work along with them with all honesty. You pursue the matter, not that person pursues. Once the ball is in your court, first, most important thing is don't try to justify. I get a call and somebody says your result is wrong, and I can see on the screen I've done it 2 times by 2 different methods, by 2 different samples, by 2 different technicians, and I'm very confident. Still, I will never say that no, my report is right. I've done everything. Rather, I will say, I think good you brought it to my notice. I'm going to investigate 24 hours. Give me time. I'm going to see right from sample collection to final reporting, all aspect as if it is my own family member's sample, and I genuinely do it. And outcome could be at times I'm wrong. The approach when you're wrong can be really different. With your honesty, patient will digest that also. And since we are talking about customer, let me also share there are 2 kinds of customer we handle. One I would call customer, one other I will call consumer. Doctor is my main customer. My approach to doctor has to be different. When a doctor calls up, suppose a Dr. Nareen calls me every month and complains about one report, and every time I say, "Nahi sir, kar diya," it is all right. He will have patience 3 times, 4 times, 10 times. After that, he will say, any I will call Nilesh, he will say report is right. Never ever he will say report is wrong. Now, suppose 10 times the report is right, but the way I say what all I did and why I feel it is right is very important, so that it feels like giving me feedback again. Now, these are some of the keys which we need to mention, and I'm sure I've been very wrong at times. We have given wrong result, and no lab can say I've never given wrong result. Every lab, if their lab, they have given wrong result. But the approach towards that, the honesty you show, the support you shown, and the pain you took, and the follow-up you did makes very, very different scenario. And this is what brings you sweet of box, I think.
Thank you so much, Nilesh. I think one needs to understand it is the presentation which is very, very important. And if you can get that act right, probably you will know what is the right direction. Over to you, Father Johnson.
Yeah, again, good morning, Colonel Binu Sharma. It's quite
Good morning,
interesting
Father
to
Johnson.
quite interesting to know that you also have a background with the Indian Army. I remember that my organization, it's a 10-year-old hospital, and the first 7 years, I had a medical director who is from Army, the Medical Corps, Major General M.N.G. Nair. I don't know whether you know him. Yeah, so he was with us. What I've always found with him is that he's very clean and clear with regard to all his communication. Probably because, you people who come from the defense background should be having a much more clearer view on how to communicate, what to communicate, on what, line, or all that. That clarity should be there. So, Colonel Binu, my question for this group is that if you can limit to your thoughts to nursing station, billing station, and discharge counter, your experiences on communication, effective communication, communication error, can you give us some highlights on that?
Thank you, Father Johnson. So I represent nursing, and I have been a nurse since 1977. So that's about 44, 46 years. Being part of the army and being part of the corporate world almost equal times, there is a vast difference how communication is addressed, how communication is done, and how deficiency in communication is handled. Army is very different. For that matter, all armed forces, naval, air force hospitals are different. Their doctors and nurses are officers. The patients who are there could be non-officers, could be JCOs, could be officers as well. In the training those days to the doctors and nurses, it continues even now. Communication is an integral part of your growing up, right from your first year to the final year. And the moment you become either a registered doctor or a registered nurse, you learn from your seniors on how to communicate. But let me come to the scenario which we all represent, all of us, which is the private healthcare world. It is so very different. And when it comes to nursing, whether communication between a nurse and a doctor, communication between nurse and the patient, communication of the nurse between other stakeholders is a big question mark. I'll say you have outstanding doctors, you also have outstanding nurses, technically. When it comes to communication, they have not been taught how to communicate. And in communication, I'm not talking of just speaking, I'm also mentioning of writing, whether it is a writing on a paper, whether it is a written order in the hospital information system. They lack efficiency, they lack technical expertise, they lack the knowledge. If I would say what happens in failure of communication between patients, if I just stick to the diagnostic part, doctors have two ways of ordering things. Either they would order on a paper or in the system. There is a failure to order on time. There is a duplicate order. There is a failure to order the right diagnostic. And believe me, nurses in our country in the private healthcare have a higher attrition. Our hospitals struggle with attrition. Anywhere between 40 to 60, 70% is the private healthcare attrition. We heard the story of Anjali who goes through a 6 a.m. to an extended duty cycle. That's not just one Anjali. There are hundreds of Anjalis every day in every single hospital because of work pressure, absenteeism, higher patient volumes. There are things to tackle every single day. You have to create not just customer delight, but customer obsession. We just had that as well. So how do you get it right? When there is a problem with the investigation which is not available, the result is not available at a nursing station, it is one person who bears the brunt of it. Unfortunately, that one person is usually the nurse because she, in the entire framework of the healthcare, does not speak for herself all the time. Not all nurses are like that, but yes, many a times they just listen from the patient family, the doctor, the diagnostic people. Also, let's consider the fact nurses are trained in so many things, but they are not very highly trained in managing diagnostics. So what is the preparation required for a particular radiology test or a preparation required for a high-end path test? We have to make life simpler for them, where if they click on a test in the hospital information system, a ready reckoner on a few bullet points on what is to be done should be available to her, which is not the case most of the time. We all assume that she knows it all. Doctors stick to one specialty. In a specialty, they have super specialty. An orthopedic doctor will also be a specialist for a knee or just the shoulder or the hand doctor. A nurse is a nurse for life. It is assumed that she knows it all, from a newborn care to the cancer care of an adult or a geriatric. So I think we need to tackle nurses differently in the entire piece of communication. We need to have loads of compassion and empathy for them We need to also have the enablers in the hospital that, okay, we all have hurdle meetings every day. Instead of saying, okay, out of the 100 things which went wrong today, 80, 90, 70 belong to the nursing. Please get it right. Nurse manager, why is your team behaving like this? Get it right. This patient is upset. This, my senior most director in oncology is upset. Let's not have that approach. No such approach is ever going to transform healthcare. Nurses who are 65% in your every single hospital have the power of transforming your patient experience, your patient delight, your patient obsession for that particular thing, your footfalls, your business, the image of the hospital. It is all in the hands of those 65% people who do 100% of the care in the IP and quite a lot in daycare and OPD, etc. Let's have a different approach. Enablers are empower them for decision making, listen to them, genuinely understand what can be corrected. They will tell you simple ways to correct these failures, deficiencies linked either to care or it is linked to your diagnostics, linked to the outcomes. At nursing station, there is so much of chaos, but can that chaos be organized chaos? We all know that hospitals are loaded. And in today's time, if you have got 100 beds, you've got 30% waiting in the emergency room to be admitted to find a bed. There's a pressure on discharge turnaround time. There's a pressure to tick all the boxes, pharmacy returns, diagnostic reports. When you are doing the completion of the diagnostic report for the discharge file, you realize out of the 20 investigations order, 5 reports are not there. When you call back, you realize those 5 tests were either never sent or rejected, or the samples came back, or the patient was not suitable and came back. But in the entire framework, no one is aware. So there are so many operational issues, but all that can be corrected by having an approach of empowerment for your nurses and empower them to handle your patients to achieve the best results. They have the power to change things, but we need to understand that nurses have that power. Treat them as individuals, as human beings, and as partners in care, not as blind followers that somebody wrote something in handwriting which cannot be read at all. Doctors handwriting, sorry, doctors in the group. We know that it is they write so much with speed that a nurse can't make out. For fear of checking with him, she will not validate or verify. She'll end up sending something, and you'll end up having wrong reports, missing reports, wrong results, unhappy administration, unhappy doctor, maybe unhappy patient. And on top, the billing, the cost, quality comes as a cost. So patient is very upset. He came to a 5-star or a 7-star infrastructure, but he did not get his reports on time. He did not get all the reports or the follow-up or the communication. And doctors and nurses have very limited time. You need to have, they don't spend so much time with patients explaining things, even at the time of discharge. Some of these key points, I think if we get it right, we can tackle the problem of orders or doctor related, of discharge, of nursing station, right in the OPD. All of this can be tackled so that we do not have all the Anjalis and the stress, a job burnout and high attrition, which definitely leads to poor patient experience and poor clinical outcomes.
Yeah, thank you, Colonel Binu. I can very well feel a lot of things which you right now said. I also have some 1,300 nurses in my organization. And the one thing which I liked is when you spoke about diagnostic and the communication, I think you point to some of the digital solutions so that they can pick at a click, they can pick and choose. I mean, it's very true. I think that should be the way forward. So thank you for that. Dr. Naren, I think another 15 minutes left. Maybe in the next round, we may have to limit to 2 minutes for each comment. Yeah,
Yes,
over to Dr. Naren. Yeah.
I was going to say that. First of all, thank you, Colonel Binu. It was straight from the battleground. I mean, somebody who experiences this every day and pointed out the right pointers which we should all take care for. And now, as Father Johnson just mentioned, we have just 15 minutes left. We had more time, so we never interrupted. But now 2 minutes per person. We have set of now 6 questions for 6 panelists. So coming back to you, Dr. Sanjay. You see, in recent times, COVID has been one of the greatest disruptors for us. And we saw a lot of things happening, changing, and new things coming up. I would like to hear from you. In your journey during COVID, did you have to rediscover your communication methods? Did you face any problems? If any, please give examples also.
Yeah, sure, Dr. Sehgal. We were one of the first labs to be approved. In fact, there were 4 labs approved on 22nd of March 2020, and fortunately, we were one of them. No other lab had the experience of actually doing COVID testing until then. The biggest challenge that we faced at that time was motivating our staff, because if we had to go to someone's house and collect a sample, why would a staff want to risk their own life and go into somebody's house even to do a nasal swab? So I think that was perhaps the biggest challenge that we faced. But all credit to the team, from the leadership down, that everybody was, in the trenches, as Colonel Nadapino would like to use that terminology. We were actually in the trenches, shoulder to shoulder with every staff. Some of the leaders actually wore the PPF along with the staff to make sure that what the staff went through, we went through the same. And I think it was 1 or 2 senior technicians that were convinced that they will take this opportunity and go to people's house. And once they saw that there's a support from the entire organization behind them, I think it was a chain reaction that took place. And then almost every staff member volunteered and said, no, I will want to be a part of this. So that was one big challenge that we overcame. The other was in the laboratory itself, in the molecular lab where we were doing the COVID testing, we had to make sure that if anyone had symptoms, we had to get them tested. And we had some people within the lab who tested COVID positive at that time. So making sure that we have a backup staff available. So we had worked with the BMC, the authorities, to transport our staff from their homes. We had a van that would pick them up at 4 a.m. in the morning, bring them to the lab. And eventually then we started keeping the staff in hotels close to our labs so that they didn't have to travel back home. And if anybody tested positive, we had a clear case of isolating them, having a backup staff available, because their entire team was exposed. So we could not do that. So I think first is working along with the team. It's not that them versus us, it is us together. So when the leadership is in the trenches with the team feels that much more reassured, more empowered, and more confident that we have the leadership support behind us. Convincing the first 2 staff members, and then after that, it was like a chain reaction. So I think leading by example, leading from the front in difficult situations is perhaps the big opportunity that we saw during COVID, that how can leadership step up and lead by example so that the team can actually follow.
Thank you so much, Dr. Sanjay. I think great learnings all of us had during COVID. And over to you, Father Johnson. I think we'll have to hurry it up.
Yeah. Dr. Deepak, happy to get back to you again. In the previous, discussion, you spoke about radiology and then the hospital at large. You also have the experience of leading the medical services of, an organization. So my question is, outside the radiology department, when you relate on the one side radiology and the other side other departments or in other care teams, can be nursing, can be the operation staff, can be the medical records team, Can you give us some more enlightenment on that respect in communication?
Yes, sir. It's more challenging doing that, and Colonel Bilu knows we work closely, and she visits Nanavati Hospital very often to work on this. Patient safety is very, very passionate to our chairman, and we work very, very hard on it. There are several ways and means of doing it, and like Colonel Binu said, we work as much electronically without having to have personal interaction between. So these are identified through a lot of combination of direct observation, incident reporting systems, which are electronic, and proactive monitoring tools in terms of collecting the data and conducting audits. The most important is incident reporting system, and we allow our nurses, junior doctors to do that very, very openly. Root cause analysis is conducted by a multidisciplinary team, which allows us to give good feedback to our CEO and also to the hierarchy. There are, Sikvara talked about feedbacks not happening. We encourage our lowest staff, including the class 4 workers, to give direct feedback. It's not easy. We have to do it continuously, and we have to encourage them rather than punishing them. The other important area which our chairman works on is direct complaints from patients and families. And we take it very, very seriously. Our morning meeting starts at 9 with patient feedbacks. And there are about 20-25 negative feedbacks that we get. And the entire core team works on it in terms of how to resolve them before 4 o'clock on the same day. And whatever happens in the night has to be resolved by 12 in the afternoon. Audits and continuous monitoring is what we are passionate about. Hospitals have to conduct regular audits, and we have to work on it. Critical information that comes out of it is very, very useful. The other thing that we do is multidisciplinary round. So together we work on multidisciplinary rounds. So nurses, doctors, and the floor managers, which we call as COs of the floor, work together in resolving these issues. What measures should be taken to resolve this communication breakdown? So there is a process implementation that we work on, standardize this whole thing electronically, training and education to new staff. We talked about, Colonel Binu talked about the attrition that we face. Our attrition is slightly lesser than the rest of the hospitals, but it's not less than 30-35%. So we need to work on that, mentoring the new nurses, mentoring the new residents. Equal problem we face is with residents. As soon as need comes by, 50% of the residents will go away, non-DNB guys. And training the new ones is a big challenge. So multidisciplinary collaboration, feedback loops, continuous monitoring is what we work on. And what we know for sure together is by proactively identifying and resolving the communication breakdowns, hospitals like ours can significantly reduce the risk of adverse events, improve the patient outcomes, and foster a culture for teamwork and collaboration. And that's how hospitals get a differentiator from the rest of the other hospitals. Thank you.
Yeah, thank you. Thank you, Dr. Deepak. Over to Dr. Naren.
Thank you, Father Johnson. Coming back to you, Dr. Rajendra Patankar, I'll make the question very short. Just tell me, what advice will you give to your workforce? What should they do if there is a communication failure?
So, for communication to be effective, we need to slightly digress to the definition of communication. Here, the sender and there's the sender and there's a receiver. We should all understand very clearly that the communication does not end when it goes to the receiver. The communication is complete only when the sender gets a feedback from the receiver that whatever he intended to communicate has been rightly understood by the receiver. And this is the fundamental thing which everybody needs to understand for the communication to get completed. When we talk about effective communication, it's not just about exchanging information. It's about ensuring that every message we convey leads to a safer and a better patient care outcome. And, it's a foundation. It's like a lifeline. And when it breaks down, in healthcare, the consequences, as you know, could be severe. I mean, just to give you an example, during my post-graduation days, I did a study on the emergency department there for understanding the situations when violence or shouting happened in the emergency room. And we realized that 80% of the reasons were due to fractured communication between the doctor or the nurse or the attendant there and the patient families. And this is something very, very important for us to understand. It tells us how critical it is important to get the communication right, because it can literally mean the difference between a smooth operation versus a crisis. And that's how, I mean, you can't overemphasize the importance of communication, whether it's a doctor, let's say, explaining a complex diagnosis to a patient, or let us say he's disclosing a death to a patient's relatives, or a nurse during the handing over or shift change, maybe an administrator who wants to share a new policy with his staff. Clarity and effectiveness in communication has directly an impact on the whole outcome of what you intend to achieve. I mean, simple things like Colonel Binu mentioned. I mean, doctors not using capital letters to write the prescription is so common, and is still very common. And although we have constantly keeping on reminding them, but we still face a lot of issues. And as administrators, we have seen that because of this, there are errors, and there are dispensing errors, there are transcription errors, and wrong medicines goes to the patient. And these are potential hazards that we can prevent very clearly. I mean, some things like I mentioned in my earlier conversation, daily team briefings or team huddles, something like that, a 10-15 minute session can really help for the whole team to be aligned to the whole process of this communication logjam, what I can say. I mean, just to give you an example, in a couple of days back, my chief of nursing gave me a situation where an unusual medication dosage, which did not align with the whole protocol of the chemotherapy given by a medical oncologist in daycare, was about to be given to a patient. It was almost more than 2 or 3 times the actual dose, maybe much more than that. Fortunately for the team leader who was there, who had a habit of actually looking into every such cases or every patient who's undergoing chemotherapy, picked it up and stopped the whole process. So, as a part of the morning meeting, we realized that maybe we should have a maker-checker concept, which is typically used by the banking industry for such critical care patients, for chemotherapy patients, where, it doesn't depend only on one person when you're handling such critical cases. It's very important that when the whole objective of, somebody said in the panel, the hero is the patient. So whatever we do needs to be around the hero, around the patient. Just to give another example, discharge process delays. If you keep the patient informed about the whole process of discharge, then he will listen to you and he'll accept to what the delays actually happen. Because sometimes delays are not because of the hospital or because of something that we are responsible for. It could be because the insurance hasn't given approval. But if you don't keep the patient informed, he looks at you as the culprit for the whole delay in the discharge process. And so silence breeds frustration, according to me. And you must keep an open line of communication with the patients during discharge process or during so many other activities that one normally does. I mean, somebody also said in between, popular doctors may not necessarily be skilled doctors. Let me tell you this. Popular doctors are popular because they have very good, exceptional communication skills. They can explain to a patient nicely in the language he understands. They can draw small diagrams in front of him. They actually get the whole patient in the system. So patient's adaptability to following his prescription is far more than a very skilled and a very good doctor in real sense, clinically, to treat the patient. And that is something which we need to look at as a good communication. Then, of course, you should be using technology, like I mentioned earlier, whether it's EMR or, again, a simple example that I can remember, our HMI system here automatically flags if a doctor writes a medicine where there is a drug-to-drug interaction. Now, these are simple things. There's a pop-up which comes up, which tells the doctor that probably you may want to consider some other medication. And that changes the whole way a negative event which would have happened. So, I mean, these are the few things that I thought are very, very important that people should consider on a day-to-day basis. And in a nutshell, what I can say is effective communication is like a glue that holds the whole healthcare system. It's about creating an environment where information is flowing freely. Mistakes will happen, but they will happen lesser in amount if the information flow is seamless. And patients will feel that they are seen and they are heard. Because the problem with patients, they don't feel that you listen to us. So I urge everyone that it is not about just inform. It is also about connecting, also about comforting, and also about healing. This is what I would like
Dr.
to say.
Pathankar, I think we should have a separate session with you. We have so much to learn from you. But the time is running out. Father Johnson, the next question.
Thank you.
Yeah, Dr. Neil, give you 3 themes: How do you relate? One is staff attrition, and number 2, communication errors. Number 3, patient safety.
So when I look at staff attrition, I think attrition is I talk about 2 types of attrition. One is pull attrition, second is push attrition. In pull attrition, there is somebody from outside who actually pulls you, gives you a great salary hike, and you decide to move on. But majority of the attrition is also push, because the culture, the ethos of the entire organization is so toxic that people will just want to run away at the first instance, or many a time would want to run away. Today's generation will run away even without a job in hand. So, I mean, how do you actually reduce attrition? I think all my esteemed panelists have spoken, and they are absolutely right. There is a portal called Vivian, and this is data from the United States of America, where it was found that attrition suddenly went up over the last 3 years, and especially among nursing and doctors. And the reason there also was same, that people said there's too much of administrative work, especially among registered nurses. So I think as medical fraternity, we have to somehow, some point of time, think of how do you actually increase the bedside time of a nurse, like the good old days. Because today when you see nurses are all the time with sheets, they are all filling up sheets. So I understand it's a quality requirement, but I think all healthcare leaders need to huddle along with quality leaders over there. I've already talked about exhaustive workload, and disconnect from management, etc. Costs of attrition are very huge without realizing it. There's a cost of training, there's a cost of hiring again, there's a cost of morale, and then also the cost of, worse patient experience, because every new person comes in with a new experience. So how do you actually manage attrition? I can't say do away with attrition. First thing is pay adequately. And many people don't understand this. Many people think, we'll build a very good canteen, but you have to pay adequately. You may not be the best paymasters, but you have to pay adequately. Appreciation we have spoken about, my colleagues have spoken about communication, Dr. Patankar has spoken about automation wherever, and getting in technology. A very, very important part of your culture, and we all should understand this, whether it is your culture at home or your culture at work, is how do you deal with your people when something has gone wrong? See, in good times, everybody deals with everybody well. It's how do you deal with people when there is an error? And many a times errors can be active errors and latent errors. So active error is like that naughty boy Neil Sequeira. When he's sitting there in the class, everybody knows that this is a mistake which is going to happen or is going to happen. It is clearly evident. Many ticking time bombs exist in organizations called latent errors. Badly calibrated machines. A ventilator which gave you a problem some time ago and nobody checked it again. These are the issues which we have to constantly look out for, and it will reduce a huge amount of burden. And if you deal with the error, the system where errors are reported, I'll tell you, I'll just take 30 seconds more. There was a psychological study done on many people who actually were driving cars and they knocked off somebody, and the person had either died or got critically traumatic in hospitals. And it was found that these people, for a long time, never took the wheel again. And this is called as a second victim syndrome. Every medical error which is done by a nurse or by a technician, etc., actually creates a second victim syndrome. It includes guilt, anger, frustration. It is how you deal when these problems happen which define the culture of our organization.
Yeah, thank you, Dr. Neil, for reminding us the second victim syndrome. Yeah, over to Dr. Nareen.
Thank you, Father Johnson. We have already overshot 5 minutes, so 5 minutes more, please. Short question, a short answer rather for a long question, Dr. Nilesh. What do you think holds more importance, empathy, compassion, or training in terms of effective communication?
So I'm going to be very short. If there is no compassion, you should not be in any profession, actually. And if there is no empathy, you can't be in healthcare. These are inevitable. Now, training is very important. Whatever answers you're giving to patient or a doctor, if you do not have background about it and you just go qualitative round with just sweet tongue, doesn't work. It doesn't create right impact. So if a patient has complained, I'm going to talk more about the challenging situation. If patient has complained, if you do not understand the complaint, if you do not understand subject, science behind it, and what can go wrong, what can go right, and what we should be confident about, what we are not, and how I'm going to do root cause analysis, how I'm going to create corrective action, preventive action, I don't think it should become front end. Now, front ending, I'm going to request all lab professionals to listen to this. Front ending in today's day is extremely important. If your goal is to become an entrepreneur, or you are already an entrepreneur and you want to have a larger scale of your work, or if you want to become a very branded pathologist or a lab professional, front ending is extremely important. Your 35% time should go with patients and doctors. Without that, you cannot create an image, and image and brand is extremely important in our profession. So that's very, very important. Now, coming to training part, training about every complaint, how can you analyze it, your root cause analysis, corrective action, preventive action. And after that, whatever is the outcome, whether you were right or you were wrong, how are you going to communicate to the patient where they start believing, patient or a doctor, I'm saying, where they start believing in what you are doing, they feel that you have done it in their faith, is extremely important. And first point for that, whenever you get a complaint or a feedback, I do not wear Metropolis hat that time. Take a hat of patient's relative. If I was patient's relative, what all I would have seen and investigated, I do that. And that is what comfort I give it to them. For me, it is not important that whether I am right or wrong. It is important that what is right for you. That is what I'm going to do exploration. I think these are few mantras works very, very well. And I would recommend them. Thank you.
Thank you so much. Father Johnson, if you could ask last question and wrap it up.
Colonel Binu, I think you're the last panelist in this panel discussion. I'm not asking you a question. Can you sum up what should be our take-home message today?
I would say integrated approach in the hospital for everything. Have doctors part of the patient care initiatives and processes. When you are having a morning meeting, call your most challenging or difficult doctor. When you are having your hurdle meeting, call that specialty doctor. Ask them for their expectations and solutions. Here, doctors work in one direction, administration in another direction, employees in third direction. All three directions need to merge into one, and we will have the most beautiful outcomes. That's my parting message.
So thank you so much for all the panelists, and thank you also, Dr. Naren, for your excellent moderation. A lot of things we heard, lot of things, points for our reflection. These are not, just for intellectual gymnastics. It's all for, our practical ground where we need to try to put into practice. So let, our patients be safe through proper communication without ending up with any error. So thank you again. Thank you so much. Over to Aparna.
Yeah, so thank you indeed. And it's exciting start with all my, I'll say, mentors of my journey into becoming an entrepreneur today. But thanks everybody. I mean, each and everyone. And I'm so lucky I've got a chance to work with each one of them. And, millions of thanks to Father and Naren sir for pulling it off so well, because I was little crazy to give some questions which were drafted as per my experience. But I'm so proud of you guys, and thank you so much. Coming up to our next panel discussion, and I have made some amends because time is precious. So all of them are my friends here in the next panel discussion. I have suggested Rabina. Parag is going to be there with me. Unfortunately, his internet is off, but he's doing it from his mobile. We have, it's a pleasure to also have, yesterday I had a chance to meet the CAP team. So I may give a minute or two to them because I have Mary here to also talk. So hi. And so Parag, Rindani and myself are going to be doing this. Most important, as our previous panelists said about missed and delayed diagnosis. So we are having two panel discussions. So part one. Hi, Parag.
I hope I'm audible.
Yes, you're audible. So I think we begin with the question directly looking at 1141. So can I have yes, I have my friend Dr. Sudeep here, who is an
Good morning.
additional professor and head of Department of Lab Medicine, AIMS. We have been closely working in CAHO, and now because our conference is coming up in February, is very active member. Sudeep, I have a question to you about there are two things. Like, I think always there are takeaway points from everybody from their experience. So what are the three most important points, out of your experience, which you think are important in cases of missed or delayed diagnosis? Can you tell us? And then we expand on that. Three most
Yeah,
important points.
yeah. Thank you, Dr. Aparna, for the question. And first of all, thank you for inviting me for this panel discussion. I hope I am audible.
Yes, Sudeep,
And
you are. Yes.
so just to bring it to the context of missed or delayed diagnosis, let me just spend 1 minute on that, because the missed or delayed diagnosis concept has been a borrowed concept, because every diagnosis takes some time. And it's not that whenever the disease process sets in, immediately a diagnosis is always achieved. So it is always a time-taking process, but the concept of a missed or delayed diagnosis has been most probably borrowed from the medical legal system and also from the insurance system. So they are more into looking into the point of view of a diagnosis, the time taken to the diagnosis, and sometimes they try to classify it as a missed or delayed diagnosis. But all said and done, it is very important from the patient's perspective that a diagnosis happens as soon as it can happen. So that is from this point or this perspective, we should be taking into account that any diagnosis that should be happening at a particular time should happen at that particular time, so as to give us the opportunity to treat it at the earliest. Now, from the lab point of view, I think it's very important that we understand that nowadays analytical aspects of laboratory services have been improved exponentially, and it's performing like anything. And so the analytical mistakes in the laboratory happen to be very rare. The most important facts that you want to address while you want to take care of missed or delayed diagnosis are things like misinterpretation of the reports that come to us. And sometimes this happens because of lack of communication between the clinician and the laboratory, and sometimes the inappropriate tests ordered by the clinician, sometimes which are not probably the right tests to be ordered at that time point during the whole life cycle of the disease. Just a small example, suppose you take a case of dengue. A patient has landed up with fever for 2 or 3 days, and you order an IgM antibody for dengue. That will not give you a correct diagnosis, because the IgM antibody will appear maybe 5 to 6 days after the onset of the disease. That at that stage, NS1 is the right choice of diagnosis. So these things should be taken into account when we talk about missed or delayed diagnosis.
Thank you,
So,
Sudeep. Can I have Dr. Neeraj Jain? Is he?
Yes.
So, Dr. Neeraj Jain, I think everybody knows, but still I have to introduce him. He is a very dear friend. We call him the quality man, kind of a person who is going across the length and the breadth of the country, training champions in various clauses and standards. So he's the president and the course director for an organization which he has formed called MELA. So, Dr. Jain, I wanted to know, as per your rich experience, you run your own organization and you are training so many young people in our field of diagnostics. What are the common causes which you have come across as, say, after Sudeep, when he comes from an organization like AIMS, what is your take on the common causes in the medical laboratories for misdiagnosis?
Thank you, Aparna, for your kind words and for inviting me here. See, in different setup, we get different reasons for a misdiagnosis. Suppose in hospital setup, for admitted patient, very common cause is patient is not identified correctly. We assume, if suppose we are getting a request, if a patient is admitted on bed number 36, we assume whosoever is lying there, that person is this patient only, patient should be identified correctly. Another thing is, when we are ordering tests, we should have good communication with the clinician. What exactly test they are selecting? Say, if they are selecting, suppose Vidal test with 2-day history of fever, and they are ruling out the possibility of enteric, so they may miss some diagnosis. And when samples are collected, then also we have to see samples are collected with proper guidelines. And this is very important in standalone laboratories and many chains who have their collection centers. People who are collecting samples, they are guided properly how a particular sample shall be collected. After that, how a sample is transported. Because these days, more than 75% samples which are collected, they are transported to different city, different laboratory, maybe different country also. So we have to follow guidelines there also. Every time when we say our laboratory is good, we concentrate on analytical part. We have this instrument, we have complete automation. This instrument is available only in our city or only in our country. But analytical part, although very important, but with lot of automation, it has reduced the analytical errors significantly. What is more important, after this analysis, correlation with previous findings, that is delta check, correlation with clinical details, correlation with IQC result, and after that, clear communication if clinician want to understand something related to diagnosis. A good communication with the clinician will help in our patient, and as a laboratory person, we will contribute in the better patient care. So these are the different areas.
So I think, thank you for summarizing that. Parag, I have to introduce my colleague, Dr. Parag. Yes. So Parag is a dear friend. We come both from the laboratory background. He's the CEO of Wokhart Group of Hospitals, very active group in CAHO, both from the hospital side, quality side, and the laboratory. So Parag. Parag? Okay. I'll move ahead. The next question is to Dr. Punita Bhatia. Punita?
Oh, ma'am, good afternoon.
You can hear me.
Yeah, I
good
can hear you. I
afternoon.
can see. Very good afternoon.
Punita is basically a senior consultant and heading biochemistries and immunoassays at Healthy and Lab. So Punita, the question to you is based around what we have been discussing, but that's the highlight, is how these delayed diagnosis, as your experience when the organization from where you come from, is impacting patient care. You have heard from the first discussion a different perspective from the hospitals, from the chain labs, and you being one of them. How do you think? Can you tell us your take on that?
Sure.
Impact on patient care.
Sure. First of all, thank you to CAHO and thank you, ma'am, and Dr. Rima for having me on board this discussion. It's an honor. A very relevant topic today on World Patient Safety Day. Delayed diagnosis, I think we cannot emphasize more on the importance of timely delivery of our reports or timely diagnosis. So diagnostics leading to diagnosis, that's important. So delayed diagnostic result can alter situations right from acute illnesses to chronic illnesses. In a communicable disease, let's say like tuberculosis or syphilis, you might end up having the patient's disease progressing and we getting more cases. Our epidemiology can change. In an acute situation like a sepsis or an endocarditis or an epidural abscess or really acute severe illnesses, the patient's stage can change. His impact of management will get affected. In cardiac markers, we cannot, emphasize enough. It's the door to lab time, the golden hour, where it's so important to give reports where they can kind of reverse the myocardial damage, where they can, go to the cath lab, take actions on that. In case of critical values, my field is biochemistry, and we have a lot of critical values in biochemistry. And critical values are, what are critical values? By definition, they are potentially life-threatening values, which need to be informed ASAP to the clinician. In fact, it's a quality indicator for JCI and NABH accreditation also. And they need to be informed to the clinician or to the nursing staff to take immediate corrective action. Otherwise, there can be a threat to life. So I cannot undermine the importance of detecting critical values and conveying them to the wards or to the doctors, and because they have to take corrective action on that. That can cost rather the life or death of the patient. And I also agree with Dr. Sudeep in saying that it has major medico-legal impact, because when you see medico-legal cases, it's there that this emphasis on delayed diagnosis or delayed diagnostics, both of them takes an important step. That's one place where we all can get stuck if we don't keep to our timelines. So both acute and chronic diseases, that's where I would say hospital setup as well as in the chain lab setup.
Okay, thank you very much, Dr. Punita, for that lovely answer, very comprehensive. I'd like to now move to Dr. Ruchika Goel. Can we have Dr. Goel's interest slide, please? Okay. Dr. Goel, you are a histopathologist, and I understand that both in your discipline as well as in biochemistry, in hematology, etc., there is a huge role for sample quality. I cannot underline how important it is from your specific subdiscipline or super specialty within laboratory medicine. But what do you feel? What role does sample quality play in diagnostic accuracy?
Thank you, Dr. Parag and Dr. Aparna, for having me here. So I feel sample quality is the most important for a histopathologist, and our diagnosis is as good as the sample we receive. Now, samples which are suboptimally collected, stored, or where there is improper fixation can ultimately lead to inaccurate diagnosis. So the pre-analytical phase for tissue samples especially is very important. I'll just illustrate it with a small example. A breast cancer patient undergoes a breast core biopsy, and the ideal fixation is between 6 to 72 hours, and your cold ischemia time should be maintained less than 1 hour. Now, if we either have inadequate fixation or prolonged fixation, it will lead to poor antigen retrieval. So when we do the hormone receptor study, you may not get good results with your ERPR. And this can then ultimately affect the diagnosis and the treatment, because then your hormone therapy would depend on whether you've given an ER as positive or negative. So a lot of times you must have seen that sometimes in the lab, you say that we have given an ERPR positive, but the outside, the blocks said that there was ERPR negativity. Now, all this depends a lot also on the pre-analytical phase, how your sample has been fixed, processed, and transported. So ultimately, if you deal with poor quality of samples, you're ultimately then again rerunning the test, which is overall increasing the cost on the patient and also on the lab, and increasing time. And this can then have medico-legal implications, as earlier mentioned by Dr. Punita also. So for histopathology, fixation is the prime thing for a good and accurate diagnosis.
Fantastic. Important that laboratorians are now talking about quality impacting cost. I guess at some stage we will get into disease-related group-based insurance. At some stage, your reports will be the dividing line between whether the hospital gets paid or doesn't get paid. And I think it's extremely important to recognize that sample quality is very. Can I have the introductory slide for Dr. Sonal Saxena, please? Ma'am, good afternoon.
Good afternoon, Dr. Parag. Good afternoon, Dr. Aparna.
Just quickly, we keep talking about audits, NABL audits, College of American Pathologists audit, NABH audits, and so on and so forth. We also talk about our daily QA/QCs. We talk about, I think Levy and Jennings both have kind of immortalized themselves into laboratory practices. How important is it for laboratories to actually invest in regular audits and to engage with the technologists and the junior level staff in regular audits? What should these audits actually focus on? And how do you personally, in your setup, ensure that the audits remain live and spirited rather than just something that's run of the mill? Over to you, ma'am.
Thank you, Dr. Parag. Good afternoon, everyone. Thank you, CAHO and Dr. Parna and Dr. Parag for inviting me over. So audits are very important, like we say, NABL, NABH, and ISO and CAP. I mean, so many streams are there. See, the important part, I think, first and foremost, is the audits really help us to identify and correct our gaps. So first and foremost, we must identify the gaps. Till we don't have a process of audit, it's very difficult. We see things, but we don't, notice them and take necessary actions timely. So very important to have proper checklist and a defined frequency where we conduct our audits. And I would say externals are just a cover its own, our internal audits, which are most important because we know our system so well. Now, when you say, how do we keep it live with our people? So first and foremost, we have to remove the fear of audit. The most important thing that I see with our people is they fail. Oh, audit, lots of paperwork to be done. Why should I do it? I mean, that's not my job. My job is to come, check the sample, test, collect the sample, depending upon which area of lab am I working in. And that should be it. Why should I be documenting? Why should I be making all those efforts? So and I find it a very, very difficult at the level of lab technicians, especially. Doctors are now much more, allowed, they understand the reasoning and they feel that it's part of it now. But technicians, it's very difficult. They feel it's an extra burden. They'll do it at the end of the day, or they may not do it even, for days together. And then when you go and see that, okay, tell me, when did you do it and how did you do it? He's looking at blanket, I did it. No, that was over. So making them feel every day that, see, what you do is important and you're impacting a life. Each tube which is coming is a life inside. We heard like CAP, like Dr. Parna mentioned. That's a motto of CAP also. So we have to just instill this every day. And tell them quality is not about documentation. Quality is about doing everything that you do in your steps. So knowing your each steps. So emphasizing on the standard operating procedures, the focus on that on each aspect. You just heard about the pre-analytical, analytical, post-analytical. We all keep doing analytical, like Dr. Sudeep also mentioned. That's where things are most controlled. But yes, I would not say that does not need a look at it. It needs to look at the consistency and effectiveness, all those steps that we have taken. Pre-analytical, yes, most important always, which we actually miss out because people there do not relate to the work that is required in the lab. They feel that it's all about the lab testing. So focus on all the three aspects and understanding the effectiveness of the actions which have come up, what actions we took and the effectiveness of it. That's the main purpose of, I think, what audit should focus, not just checking the documentation, but retrieving what it impacted and how it, improved the system and there was effectiveness of it. Training effectiveness is very important because that's something we keep missing out. We train our people, we don't see the effectiveness. And most of the times what I've seen, we keep taking corrective actions. We land up with some amended report. We've taken an amended corrective action. People have not realized how to make it effective in future. It happens again. So that's, I think, is the, important thing that I see. And now with the, improvement in the standards and the upcoming things that we come up with, risk assessment in the audits, upcoming thing, because we still need a lot to learn, is to understand and identify risk and mitigate them rather than waiting for an error and taking a corrective and preventive action. I think that's my main pointers that I want to fit in more so in a comprehensive way. The rest is all the details as we know about the clauses, and we can just go on about the machines and the environment. Nothing is lesser. Everything is very, very important.
So thank you, Sonal. We are into continuous, CAHO is committed to safer patient care finally. So we are going to be working with this team also for risk assessments and many more, workshops in future. So thank you. Just one, I would like to we have with us the CAP team. We have Angra Wong and we have got Mary D'Souza, who is the Senior Vice President CAP, that is College of American Pathologists. I had the pleasure of meeting all of you yesterday along with her, and we had a brainstorming session over lunch where how CAHO can be with CAP to spread knowledge, train champions, and help people to work in better quality control processes so that ultimately all of us work for safer patient care. So can I have Mary D'Souza sharing a couple of minutes? Welcome, Mary D'Souza.
Oh, thank you, Dr. Aparna, for inviting Angra and myself to join you for this very, very important webinar. And I recognize so many faces on this panel from an exciting week in Delhi. It's very good to see you all again. I just want to make a few comments about what has resonated to me this morning in this very, very important webinar on patient safety. But first of all, the College of American Pathologists is the leading provider of laboratory accreditation, proficiency testing, or EQA, quality programs, and cancer protocols and guidelines globally. We appreciate CAHO for highlighting the value of quality diagnostics to improve patient care. As this panel has highlighted already, accurate diagnosis supported by thorough audits and processes is really at the heart of effective healthcare. And this is where the CAP accreditation comes into play. The College of American Pathologists accreditation is a mark of excellence in laboratory medicine. It signifies that a laboratory adheres to rigorous standards set forth by the pathologists who are members of the College of American Pathologists. This ensures the highest quality of diagnostic testing. This accreditation process involves comprehensive evaluations of laboratory practices, from the accuracy of test results at all phases, pre-analytic, analytic, post-analytic, to the qualifications of personnel and the maintenance of equipment through peer-reviewed inspections. For patients, the CAP accreditations offers reassurance. It means that the laboratory handling their tests is committed to upholding the highest standards of quality and reliability. And this not only increases the likelihood of accurate results, but also enhances the overall efficiency of the diagnostic process. CAP accredited labs undergo regular inspections and must demonstrate their proficiency through proficiency testing or external quality assessment and adherence to best practices, which translates into dependable and timely diagnosis. The CAP's accreditation and quality programs, we believe, support laboratories in achieving these high-quality diagnostic testing results and supporting patient care for patients and their families. Knowing that their diagnostic tests are handled with the utmost care and precision brings peace of mind and confidence in their healthcare journey. So, Dr. Aparna, thank you once again for including us in this important conversation, and we look forward to working with healthcare in India.
Very soon, Mary, and I can't wait to hear back from you. We are all there. And thank you so much for joining us, though it was a last-minute invitation.
And again, thank you. It's been an honor. Thank you, Dr.
Can I have the next introductory slide for Dr. Ruchi Kapoor? So thank you, Rima, for getting me introduced to this young baby into the group. She's a national lead for Tata 1mg. Very rich experience. Ruchi, I wanted to understand from your experience that, when there are interpretation errors, be it pre-analytical or post-analytical, like we saw yesterday, or analytical, what's the impact on the diagnosis overall? We are not talking perspective to a biochemistry or a histopath. How do you think, out of your experience, you want to highlight that here? Ruchi.
Thank you, Dr. Aparna, Dr. Parag, and obviously Dr. Rima for introducing me on this platform. So, yes, errors in the laboratory test interpretation, they can have a significant impact on our diagnostics. Just to say a simple, they can lead to misdiagnosis, wrong diagnosis, false positive, false negative results. They may mislead the clinician and can lead to overdiagnosis, underdiagnosis. Simple examples like raised tumor markers in some benign conditions, or a break in cold chain, especially to give you an example, PTH. there are some time-specific sample collections, example, cortisol, or as has rightly been pointed out by previous panelists, dengue NS1 being done after 7 days. We all know about the cross-reactivity and false positivity in the case of typhi.IgM. Urine culture, after sample being collected, after starting the antibiotic. The daily we face high potassium because of delayed separation between the serum and RBC, to name few. These are the examples. So all this can lead to missed, wrong, and delayed diagnosis, leading to further additional tests, follow-up visits, and inappropriate, ultimately leading to inappropriate treatment. And this all collectively comes to zero down on increased healthcare costing. And most importantly, we can see the patient, the anxiety, it leads to stress and anxiety, and importantly leading to the loss of trust of the patient. So there is diagnostic stewardship. That means right test for the right patient at the right time with right information, which this is all necessary for to optimize the clinical care. So very importantly, the communication between the laboratorians and the clinicians is very, it will go in a long way to address to reduce such incidences in the future, and especially also the training, the importance of the trainings and the strict quality processes. So all this can help us to reduce these errors in the interpretation of the laboratory results. Thank you.
Thank you, Ruchi, and we are going to interact more. Can I have the slide for Tushar? Yeah, Aarti, you will be able to join us very soon. We are sending you the link. Ravina, slide for Tushar. Okay. So when I started planning this webinar, we really, both of us thought that we need somebody from the software and the hardware and that perspective. That's when I got connected with Tushar. Tushar, my question to our question to you is, one, we all know that technology is the in thing. There are daily new things coming up. But out of your experience working into healthcare, how do you think, what's your take on the theme, which is missed or delayed diagnosis? How is this technology, be it auto authorization, be it sending the reports, or having electronic health records, is helping in reducing or minimizing errors in diagnostics? Mr. Tushar Prasad.
Yeah. So hi Aparna, hi Parag. Thank you for giving me this opportunity. Hope I'm audible. So yeah, means based on the question, Aparna, I'll say like the electronic health records. So using the technology, using the software which are presently on there, so it can improve the timeliness of diagnostics by streamlining data sharing and tracking the test result, the previous test result, the future test result which is going to come, and also because of those trends, we can flag the anomaly of the findings, and based on that we can do the follow-ups. So yeah, that will be a great help, and also it will also promote easier or facilitate better communication between laboratory staff and the healthcare provider.
So I think that was very informative.
And very crisp.
Yes, and very much so. I think Parag, Arun
Okay.
Harith is waiting for you. Yeah.
Yeah. Can I have Arun's introductory slide, please? Dr. Arun Harith. Dr. Arun, while your slide comes up, we had a little discussion sometime back on our pre-group. There is this whole thing about only the diagnostics. Just for everybody's information, while the designation reads CEO, I'm basically an MD in microbiology with about 15 years of diagnostic laboratory experience. And I've seen both sides. I've seen the clinician side, I've seen the laboratorian side, and therefore I understand everything. I understand the way tests are ordered, sometimes sequentially, sometimes cost-wise. There is a strategy in place to do one by one. Sometimes people just dump 50,000 tests together on the patient. But essentially the choice of tests and then the report thereafter goes fundamentally on the principle of garbage in, garbage out. You don't order the right test, you don't send in the right quality of sample, there's a pre-analytical variable, there's a pre-analytical error. What are your thoughts on the garbage in, garbage out concept, that if you don't send the right sample, you're not going to get the right report and therefore not treat properly? And how do you think correcting this will help or address having missed or delayed diagnosis? Over to you, Dr. Arun.
Audible? Am I audible?
Yes, Doctor. You're audible.
Yeah, thank you very much for having me in this discussion, and I may be a bit passionate in what I'm saying, so if I cross the limits, my apologies before. The quality of a report released by a lab is a direct function of what is the sample that comes inside. If garbage comes in, garbage is going out. Okay. When we talk about a test process, the right test should be ordered on the right patient to reach the lab at the right time for the right report for the right management. So there are a lot of rights over there. We'll address two issues. The first issue which we'll be addressing is the right test, and then we'll talk about the right sample. A previous pathologist in the previous panel discussion said something which actually resonated with me, that if a report generated from the lab doesn't sync with the patient, don't simply start off and pull down the shutters by saying that my lab is right. Do a thorough investigation as you would investigate if you were the patient, and analyze yourself and find out where the cause was. There's a good 70 to 80% of the chances that the problem wouldn't have been in the lab. If it is in the lab, it's a different ball game to address. We're not discussing it right now. So we're just talking about the right test being ordered and the right sample being sent to the lab. Now, the problem with the right test being ordered, I think we all should be very sensitive to this issue. The clinicians read their textbook on how a patient should be evaluated. The lab guys read their textbook on how the test is and how this test interpret with the patient. But nowhere do these two people intersect and discuss, is your book talking the same language as my book is talking? And that's where the problem comes. There should be communication. But communication, when I'm saying, should be bilateral on a common platform, right? NABL says lab people should have clinico-pathological correlations and discuss with the clinicians. We are running behind them. But the flip doesn't occur. The loop should be closed from both the ends, and there should be a mutual respect for us to bridge this gap that the right test is ordered to the right patient. We need to ponder about it. Sounds very harsh. Just keep it in mind. We can build upon it later.
Absolutely. Yeah. Go ahead, Dr. Harit.
The second point is about pre-analytical errors. We talk a lot about it, but if you look at literature, nothing much is being done about it. And I'll tell you why, in my perception, this is all my perception. You get a result which doesn't resonate with the patient, you send another sample, you've got the correct result, you manage the patient. So pre-analytical will not harm a patient. It may delay the diagnosis, it may delay the management, it will not harm a patient. And as long as the patient is not being harmed, things are very good. But what I want the world to be sensitized about is a pre-analytical error indicates that our patient is not in safe hands. What is the cause is a different issue altogether. The hands that cannot collect a sample properly and send it to the lab, for whatever the errors in the chain, we're not pinpointing it. The hands that could not collect a proper sample and send it to the lab is liable to repeat those errors in patient management. Now, this is the point we should look at. If you get a pre-analytical error, there is a break in the chain. Maybe the person who's collecting the sample is over. Maybe the person who's collecting the sample doesn't get the proper pop-ups as to what is the thing to be done. But what affects sample collection will also similarly affect the IV drips being given or the antibiotics given. So when we look at a pre-analytical error, if we tell ourselves that our patients are not in safe hands, we will probably give more focus to this and make the system well, and then our patients will be safe. These are the two things which I wanted to address.
Very interesting, Dr. Arun. Very interesting. While on one hand, there is a lovely backhand volley coming from you on the tennis court, there is a constant barrage of tennis volleys coming in from the clinician's end.
Yeah.
That laboratorians and radiologists have basically become armchair doctors, and they are rarely at the bedside. That's just another point of view. I am not saying it's my point of view.
No, I agree with you. I fully justify with you.
So my question therefore, and I move on to Dr. Aarti Khanna-Nakwal. Could I have her introduction slide also being flashed so that our 2,500 plus people who have actually registered for today's CAHO World Patient Safety Day celebration are able to get a glimpse? Dr. Aarti, the question, I'm sorry, you just come on board and the Google is coming to you, but I know that professionally you will handle this question very well. So we have this whole role of communication, which cannot be overemphasized. We have the role of, this question comes in two parts. What is the role of communication with the patient in preventing delayed diagnosis? And how much effort do laboratorians and all diagnosticians, in fact, radiologists as well? Surprisingly, we don't have a single radiologist on this panel. I guess there's somebody on the second panel. How much of importance do you put on communication between doctors of various pathies, such as the surgeon, the pathologist, the histopathologist, the biochemist, the physician? When I was in medical school, there was a big joke that at some stage there'll be an orthopedic surgeon for the left hand and one for the right hand. I guess laboratory medicine is reaching there. Your view on patient communication in preventing delayed diagnosis and in doctor-doctor communication in preventive diagnosis. Dr. Aarti.
Thank you very much. I hope I'm audible.
Yes,
very good afternoon to everyone. Thank you, CAHO. Thank you, Dr. Aparna, Dr. Parag, for having me, and thank you, Dr. Rima, for introducing me to CAHO. So I feel that we all are aware that 70% of clinical decisions are dependent on lab diagnosis. And we all know that the maximum errors happen in the pre-analytical phase. So I feel that patient communication actually starts even before the sample is collected. So effective and clear communication is important at the time of sample collection, because the person who's collecting the sample, it could be a phlebotomist or a nurse, should ensure adequate patient preparation. It could be something simple like fasting, something simple like stopping some medication for a coagulation test, or knowing the right time of medication for a therapeutic drug monitoring, or just at times the last menstrual period or ultrasound findings are required for certain tests. So the clear communication starts there at the time of sample collection, because maximum errors are happening at that phase. And also at that time, the patient should be communicated about the turnaround time, so that the patient can plan accordingly, because not all tests are being run or being processed every day. For some tests we have certain run days, so it's important that the turnaround time should be communicated to the patient. And once the results are ready, if there's anything critical, then that has to be informed to the clinician or the patient according to the lab protocols. And if there's anything abnormal, either abnormally high or low, it should be highlighted in the report. So, being in a standalone lab, you can't actually communicate with every patient. You can't talk to every patient, but your report is like a prescription. So it should, clearly mention, there should be comments, and there should be a proper interpretation in the report, because that also constitutes effective communication. So if there's something like, a maternal screening test or a newborn screening test, that has to be mentioned in the report that this is just a screening test. And in case it's screen positive, then what confirmatory testing are required, that should also be mentioned in the report. And the other thing is that in case there is some delay because of any big breakdown or any other reason, it happens in every lab. So that has to be communicated to the patient. So then the patient can, plan accordingly. And then the new turnaround time should be communicated to the patient that, there's a breakdown in the lab and we apologize for it. And the report would be ready maybe after 3 hours or 4 hours. So that has to be communicated. The other thing is that lab should be very transparent about any errors which are happening. So if there's any error which has happened, you have to be transparent and communicate the same to the patient. Because, if there's any wrong report, that can create havoc. It can lead to over-investigation. It can lead to over-treatment, mistreatment, delayed treatment. So lab have to address these, problems effectively and take adequate corrective measures. And if an amended report has to be released, it should be done and effectively communicated to the patient as well as the clinician.
Okay, that's a very interesting take, informing the patient. I guess, I don't know. I know we've got our colleagues from CAP also here. I don't know whether India as a society is ready. One thing is definite, we have become more litigious as a society. Aparna, over to you for the next few questions.
Yes, Parag, I completely agree. Thank you, Aarti. Can I have our Sonal Saxena here? Because Punita is, yes. So when the slide of Sonal is getting loaded, I have, because there are some questions which are kind of the same theme, I would like to ask, yes, hi Sonal. So
Hi.
I would like to ask you, and maybe also take view from one of the other panelists, that what do you think, whatever we say will inform the patient, as Parag said, or with the CAP people here, when we tell the patient that, okay, this is an amended report. I think all of us work as you saw what Nilesh said or what Dr. Arora said,
Yeah.
Empathy and all that. But sometimes patients are really not willing to listen to you, when there is a delayed report or a misdiagnosis, and they take the legal way or threaten us in that way. So how do you think, all of us have faced it at some part or handled it? So what is your take on that?
So see, when we are dealing with a patient who is not satisfied because, we have not given the right report and we have not probably communicated well on time, communication, like Dr. Aarti mentioned, becomes very important. So we see this happening. It's not very uncommon. We've seen cases wherein fight is happening over TSH. I recently spoke to a patient who was just not ready to accept that TSH has a circadian variation and there are things which impact it, and TSH is not a thyroid hormone. Just to explain them that it is not a thyroid hormone. It's something that gets impacted with our mental stress itself or how we have spent our previous day. So we see those fights, and I think every level what we try to do is talk to them again and again at different levels. So first probably starts with our customer care representative, wherein obviously he just fails because they feel that, you're not talking technical. And when it comes to people like us, wherein we have to explain things and tell them that, okay, give them references, because now everybody is so savvy and so educated comparatively the kind of patients, especially in cities that we get. They themselves read up much more than the doctors, and they try to, become, through the Google doctor, become masters of their own things. And they say, I know my body better, but they need to be guided in a different manner and then taken through the textbook the way we have been taught and take them in that direction. That's one thing that I see. But yes, when a case of amended report happens, see, like Dr. Nilesh mentioned in the previous, session, it's very important that you turn on their side. You be on their side and tell, okay, if it was my, family member, how would have done it? I remember a case long back wherein, a patient, one of the reports went haywire because somehow we missed to release a potassium, which should have been corrected. It was probably a pre-analytical issue and value was coming higher. And we released a report which mentioned, which could have, led to a, obviously a wrong diagnosis and a scare to the patient. And he obviously questioned, and he was right. I had to go on his side and explain to him that, fine, I understand the point that raised. It's been a miss. I will be releasing a documentation on an amended report. And like CAP advises, in the amended report, we need to mention what happened. It's very difficult to accept mistakes. So when we are mentioning on that point that, yes, this, and there is a now clear-cut defined, statement that we have given to all our labs, whether CAP accredited or not. It's like a universal thing to go to everyone. This is an amended report for this parameter. This was the previous value. This is the, the revised value. And this is, the previous report has to be treated as null and void, something we used to mention earlier also. But now a declaration that what was corrected. And when it's about probably a whole test, like a CBC run on a wrong sample, because somewhere somebody pre-analytically wrongly labeled it and we couldn't identify because we couldn't see those, gaps. It started from the source of origin. Therein it's about the whole test that we mentioned. So that's where going on to the patient's side, listening to them, very important, because all their things should come out. Whatever they want to say, yes, they were very offensive and they go very bad with their language also. But most of the cases there are still we are able to control. But yes, there are cases which go further on to the medical legal aspect and communications happen, and that's where our peer reviews and everything helps, and it takes over that way. So that's what my take is.
Very interesting. We should have had all their bosses also here, Aparna, as to how the interaction is expected to go between laboratorians on one side and the CEOs who bear the brunt of the financial implications of all of this. Aparna, you'll. I think there is a last couple of questions,
Yes,
Aparna.
yes. So I have this question for Dr. Neeraj and Ruchika chipping in. That after listening to all this, it's easier said, but when you're in that position, what do you think have been the recent advances in the laboratory, which you think have been done in India? What can be done, we all know, but what has been done? Can you give us your input over the next 2 minutes, because we really want to be sticking to the time. Dr. Neeraj and Dr. Ruchika.
See, if we see in the past few years, maybe you can say the last decade or in last 2 decades, there is a lot of emphasis on the immunohistochemistry, and people are not now going beyond immunohistochemistry also, fish, and they are now chromogenic in situ hybridization also, because we want to develop advances so that we are actually contributing in the patient care. Same thing is happening in our other fields, like in biochemistry. We are going for total automation. If you see around 2 decades back, interfacing of machines with the computer, it was hardly visible in many laboratories, but now most laboratories, they are going for this interfacing. And barcoding is also available in not all laboratories, but in many laboratories. And we are also understanding it is very important to discuss with the clinician. So interaction with the clinician is also happening. Previously, people were thinking, before this accreditation started in India, our job is to perform the test and to release the result. Now we are understanding a good quality sample is very important, and it is possible and only when clinician is properly informed about that. And we are also helping them in the correct interpretation of the result and what are the further tests which can be done in any particular situation.
In fact, now we are moving on to AI, artificial intelligence and pathology, which has become the flavor of the season. And there are algorithms being developed. They are being used in West somewhere for research purposes. And they have found to pick up subtle anomalies which have been missed by the human eye. And maybe eventually this would also become a way of reporting. We already have digital pathology and telepathology now, and people sitting far away can take expertise in breast pathology or GI pathology. You may be a general pathologist, but if you have digital pathology, you have that the advances to get knowledge and information. And then we have next generation sequencing, like Dr. Neeraj was saying. Now, moving on from IHC and fish, we have next generation sequencing, which is picking up molecular mutations for infectious diseases. And from these diagnostic, we are moving towards personalized and precision medicine. So I think, yeah, there is a lot of advancement going on in the lab diagnostic per se.
Thank you so much, Dr. Neeraj, Dr. Ruchika. And in the interest of time, we've been frantically signaled by our organizers that we need to wind up. So I was supposed to have a couple of more questions to Dr. Sandeep Datta, Dr. Arun, Harit, and Tushar. My apologies, we'll not be able to take those questions. Just a last quick 15-second wind up from me. There is no way in which we can undermine the importance of diagnostics in today's day and age. We are moving towards more and more evidence-based medicine. Important for all diagnosticians to realize that you are extremely, extremely important and relevant, and more so today than earlier. And extremely important also to understand that your role in patient safety and healthcare quality cannot be undermined. Therefore, it's important for you also to recognize this and take on this responsibility, educate clinicians where required. I believe it was it Dr. Arun who said we have, or somebody who said that we read different textbooks, it's important for you. Earlier, we used to have the clinician was trained at PGI Chandigarh versus Jipmer Pondicherry. Now we have the laboratorian within PGI Chandigarh is reading a different textbook from the clinician at PGI Chandigarh. Request us all to get onto evidence-based medicine platforms, have similar same care pathways across the country. And that's what will really get us ahead. CAHO stands for patient safety. CAHO stands for quality, healthcare quality and healthcare quality improvement. And the laboratories and radiology specialists are extremely important for this. So with that, an extremely big round of applause to all our panelists, and of course, to my leading voice, Dr. Aparna Jairam, who heads the laboratory division for the nation and the world on behalf of CAHO. A big thank you to all of you. Remember, at the end of the day, the revenues do come in from labs, but we need to ensure that our patient safety remains paramount. Thank you very much, and back to our organizers. With that, we end this panel discussion. Thank you, ladies and gentlemen.
Thank you.
Thank you.
Thank you.
Thanks a lot.
Thank you.
Thank you.
So without further ado, we have our Dr. Suvin Shetty and Dr. Shweta handling the part 2 of missed and delayed diagnosis panel discussion. Can I have Dr. Suvin?
Yeah, we are there. Yeah,
yes,
we both are there.
all the very best.
So,
we have
yeah.
stuck to the time, and thank you, Parag. I really love you for that. Thank you.
Thank you,
I'm sure
Panya.
we'll do the same. Yeah.
We will ensure that the legacy continues.
Thank you.
So, good afternoon, everyone. We move on to the second part of the panel discussion. Topic remains the same. We have labeled it as part 2 of the panel discussion on missed and delayed diagnosis. Let me introduce myself. I am Dr. Suvin Shetty. I at the laboratory at Department of Laboratory Medicine at Dr. L.H. Hiranandani Hospital at Mumbai. And with CAHO, I am the Vice Chair of the Quality Professional Wing. And along with me, we have Dr. Shweta Prabhakar, Madam. Over to you, Dr. Shweta, to introduce.
Thank you, Suvin. And I'm Dr. Shweta Prabhakar, Head Quality and Patient Safety at Fortis, and I'm also the North Zone Chairperson at CAHO. It's my immense pleasure and honor to host this panel discussion along with Suvin. Moving on to our panelists, our esteemed panelists, I would like to invite Dr. Ghosh. So Dr. Ghosh, may I see you? You're there in the
he's there.
Session. Okay, Rabina, can we? So that's here. Dr. Ghosh, welcome to CAHO's panel discussion. He's a director at Neurocritical Care, and he's a leading radiologist at Curie AI. He's got immense experience at hand, and we'll grab this opportunity to extract more and learn more in this session. Our next panelist is Dr. Reema Bahari. She has got over 25 years of experience in healthcare and diagnostics. She is also a North Zone CAHO Diagnostic Division representative and an NABL assessor. Welcome, Dr. Reema. May I see you? You are most bubbly person around. Can I hear a big hi from you?
Hi.
Yes, I know your voice is down, so that's why I wanted to ensure that. So great. Welcome. Over to you, Suvin. Let's have the other panelists introduced.
Yeah, I'll introduce my other two panelists on board. Miss Jennifer Tamil Priya. Sorry if I have mistaken the pronunciation of the last. She's the engineer in the Department of Biomedical Engineering at CMC Vellore with 6 years of experience in the field of biomedical engineering. Welcome, Jennifer. I'll also introduce my dear friend Vinod. Where are you, Vinod? Vinod. So I'll introduce my friend Vinod Kumar, who I know for many years now. He's a BE in Mechanical Engineering from PSG College of Technology in Coimbatore and has a vast experience in the field of engineering, design, and implementation. And currently is the consultant of engineering and safety at Rajagiri Hospital, Kochi, as well as he chairs the engineering forum at CAHO. Welcome, Jennifer, as well as Vinod, sir. Welcome.
Thank you. And today is Engineers Day also.
Oh, yeah. Happy Engineers Day. What a privilege I had to introduce both of you.
Thank you. Thank you so
Happy
much.
Engineers Day to Vinod and Jennifer.
Thank you, Dr. Shweta. Thank you, Dr. Suvin.
you. Ravina, yeah, thank you, Ravina, for sharing it. And let's have a wonderful discussion. So, when would you like to start first and grab the radiologists and the laboratory professionals first
Yeah,
in
I'll do
the
that.
discussion?
Yeah, I'll do
Let's
that
do
because
it.
I think, yeah, I happen to come from the same diagnostic domain that they are also part of, and the theme being for the Patient Safety Day this year, being focused on diagnosis. Though I'll say, as a fine print, laboratory or the imaging is one part of the diagnosis. Actually, the diagnosis also starts from the clinicians themselves, the patients themselves. We possibly will try and also focus on them, the clinicians, the decision makers, the patients. But as a startup, let's start with Dr. Rima. She's a senior biochemist and heading the Department of Lab for a long time now. If I have to ask with regards to the role of diagnosis in patient safety, how critical is accurate diagnosis to ensure patient safety from a laboratory perspective? A very specific, general kind of a question.
Thank you, Dr. Suvin, for this question. But first of all, I'd really like to congratulate CAHO for taking this theme of World Patient Safety Day, and thanks to WHO for giving us a theme. Because I feel a role of diagnosis in patient safety, it has tremendously changed, as we all know, from the last 20, 30 years, when patients used to walk in a clinician's room and clinicians looking at them would have a couple of differential diagnoses in their mind. But today, I think without the labs, without the radiology, without the investigations, they cannot at all even think of, starting the treatment. So critical is the role of diagnosis and accurate diagnosis in patient safety. From a simple test, if I may have to give an example of blood sugar, as simple as a simple test like blood sugar, say, for example, in gestational diabetes. Now today, first of all, happy Engineers Day to Vinod. We are so dependent on machines and calibrations and accurate, for giving accurate results. Suppose the machine is not calibrated and they are measuring the glucose and it is inaccurately measured. If the gestational diabetes considered it is not correctly diagnosed, the impact can be on fetal harm. It can cause a fetal harm. So to that, a serious nature, inaccurate laboratory investigation can impact the patient safety. Another example, let us see high-end test of hormones in IVF treatments, precious IVF treatments where there is a lot of emotional baggage which the couple is carrying and finally deciding on to move into an IVF clinic. And these results are so critical in deciding for the clinician whether to give triggers and whether to, stimulate the patient because of their stringent protocols. They are dependent on the hormone levels, on the accuracy of that they can, the whole cycle can go waste. And depending upon if the results are wrong. So therefore, correct results are very, very important for a clinician, for their diagnosis, and for moving ahead. There are so many examples we all know, from simple test of electrolytes every 2 hours in ICU. If they are delayed or if they are not given correctly, what all can happen? Prostate, PSA, a simple test can differentiate whether, it will give a clinician, it will give a surgeon which way to proceed, a conservative management or a surgical management. There are so many examples. So I think the role of diagnosis in patient safety is tremendous. And today's doctors, today's lab doctors are actually, they aid the clinicians and they are actually the doctors for the doctors. So for the patients as well. So I think there is no way that, they have a backseat or they are just in the lab and just to sit behind the, in a corner. I think they have to come in the front end and have a complete holistic view of giving the accurate report after managing what is in the lab to the patient. Let me begin
Thanks,
with
Rima,
this.
for the initial thoughts. Yeah, thanks. Over to you, Dr. Tamangna. Same question remains the same, but I want from a radiologist's point of view.
Right. I hope I'm audible.
Yeah, you are.
Thank you so much, Team CAHO, Dr. Shweta, Dr. Suvin, for having me. It's an absolute pleasure and an honor. I think, from a radiology perspective today, I think as many of our esteemed panelists already kind of alluded to, is that radiology serves as a cornerstone of modern medicine. And missed and delayed diagnosis can have far-reaching consequences. So it can either delay treatment, it can exacerbate disease progression, or even lead to like poor patient outcomes, including preventable morbidity and mortality, right? And in my experience, I think, when we're talking about inaccurate diagnosis or diagnostic errors, like I feel that it happens in like three broad scenarios, right? So it could either be a delayed diagnosis. I think we talked about timely diagnosis, or it could be incorrect diagnosis itself, or just a misdiagnosis, right? So if you're talking about delayed diagnosis, whenever there's, despite having sufficient information already available to make a diagnosis, we end up spending additional time in conducting further imaging or investigations, right? And this leads to delays in treatment with a negative impact on patient outcomes, obviously. For example, I predominantly work in stroke. So, in ischemic stroke, most often than not, the patient usually undergoes a screening non-contrast CT head. And much of the times you'll actually have very subtle early ischemic changes, which are already visible on the scan. So coupled with this subtle finding and a very strong clinical suspicion of stroke, it's actually enough for the patient to then quickly be, instituted intravenous thrombolysis, right, within the window period. But more often than not, the ground reality is that, these patients are usually transferred to a MRI-equipped center, and they'll undergo confirmatory imaging before any kind of, treatment is started. And this has devastating consequences for the patient, because for every minute that's lost, we're losing tens of thousands of neurons. When it comes to, incorrect diagnosis, I think we have to obviously accept the notion that, error is basically an inevitable part of being human. To err is human. So such mistakes do happen, but we should also kind of remember the consequences of it. So in my experience, and I've seen this a few times, a simple benign hemangioma in the liver, for example, seen on ultrasound as like an hyperechoic focus, right, can be confused with a liver metastasis. Somehow they thought that, I should include it in as one of the provisional diagnosis. And then it initiates like a cascade of expensive and invasive and time-consuming set of investigations, including biopsy. And this causes, a lot of pain. Of course, it has its added risks of morbidity and sometimes even, God forbid, death. On the contrary, if we are not provided that proper clinical background regarding the patient and what the clinician is actually thinking, something like a solitary metastatic lesion in the liver, which again has almost exactly same picture on ultrasound, can be mistaken for a benign hemangioma, and the radiologist ignores it. And finally, coming to misdiagnosis, I think I'm not sure how often this happens in laboratory part of diagnosis, but definitely it's sadly it is a thing that we deal with in radiology more often than not. Like, for example, tiny pulmonary nodules. These are notoriously difficult to spot on HRCT chest, right? And we are talking about these nodules which are just a few millimeters across in diameter, right? But the difference between spotting a potentially malignant lung nodule, right, early, when it's a few millimeters across, could mean the difference between a patient having almost 100% chance of survival, or presenting 6 months later again to your scanner, with obvious symptoms and local spread and a very poor prognosis. So overall, the accuracy of diagnosis coupled with prompt communication and minimizing the delays are essential to basically safeguarding patient safety in radiology. And if we have to improve diagnosis to have better patient safety, radiology must be at the forefront of this effort. Yep.
Yeah. Thanks, Dr. Tamagna. I completely, just to summarize what both of you mentioned was, almost according to certain literature, it talks about 60 to 70% of the medical decisions are being taken with the help of diagnostics at hand. That the reasons may be varied, but definitely majority of the clinical decisions are being taken with this, and criticality of the accuracy as well as timeliness of the diagnosis is a must when we consider that this is the background of it. Over to you, Dr. Shweta.
Yeah, so when in fact, Dr. Reema and Dr. Ghosh, it's also important. You did mention about, communication. It's very important that we have an interdepartmental communication. And I would also, would like to, initiate a thought that what's your take on appropriateness of an investigation? So when we start with diagnosis, it is also important that we have that seed to be sown that the clinicians, when they are ordering a investigation, it should be appropriate to adjunct to the treatment or the diagnosis line. So what's your consideration on appropriateness and a communication, an effective communication, because at times a requisition comes in and there is a challenge. I'm sure both of you would be facing that the clinical aspects are sometimes missed in that. So you don't get a picture that who, for whom, or for what we are, investigating or diagnosing. So that's very important. What's your take of, if you can just quickly,
Dr. Reema, Dr. Ghosh, if you want to contribute on that.
Want to contribute to this particular thought.
Let me initiate this rather. Dr. Shweta, when it comes to appropriateness of a test, which is very key.
Yes.
In fact, ISO 15110 actually touches upon it as one of its subclause. I'll give you an example. Bleeding times, clotting time was a very important example when it comes to appropriateness of testing. Whether should we do it, whether we should not do it. But there are now other tests which have come in the vogue where BTCT is not possibly required. So what I'll give you an example. What I should try and brief or inform my clinical friends is that these tests may not be required when it comes to what exactly they are trying to seek. What it has become is it's become a practice as a pre-surgical or pre-operative that you include these tests as part of the package, whereas it may not give you enough or the information that the surgeons are trying to seek. So in a way, these are all obsolete tests which possibly can be done away with, but our practices and possibly the textbooks still refer to some of these obsolete tests, and we end up still asking or requesting for these tests which may not be appropriate. So I'm just giving one small example that may.
I mean, that's wonderful. I think so. That's quite adds value to our what we are trying to discuss here.
Yeah.
And taking a clue from here, where when we move, because all both radiology and laboratory are they are also dependent on the technology and the equipments, and there comes in our BMEs, and their role of the BMEs are very important. And here I would take an opportunity to take a first-hand insight from Jennifer. If you can give me, there would be some challenges, or there are some things which you think that there is, we need to work on and upgrade our technology or knowledge or awareness regarding how to handle equipments effectively, so that we ensure that we improve diagnosis. So is there any, can you take up and apprise us about this aspect?
Yes, ma'am. Thank you. Good afternoon, all. And thank you, Kaho and Dr. Aparna, Swin, and Shweta, ma'am, for inviting me to be part of this panel discussion. As ma'am, you have said, so there are technologies has been evolved recently, tremendously over the years. And it is driven actually by the need for accurate diagnostic tools, and patient safety has to be taken care of by end of the day. And innovations have not only been restricted, but it has been wide range to enhance the quality of the imaging quality, and meanwhile minimizing the risk associated with the procedures also. And where we can avoid the misdiagnosis or delayed diagnosis. And modern radio diagnostic equipments are handled, and now it has been more portable and integrated with cloud computing, AI, and which help us to make the faster diagnosis, and take the procedures or tests being carried out under remote locations also. And in addition to the hardware part, the software advancement has also been into place, where we have image processing algorithms providing more detailed visualization of the internal structures as Dr. Ghosh said, where we can visualize the human body very much clearly, which will provide for as a tool for the accurate diagnosis and making the procedures faster and more comfortable for the patients, ensuring the safety. And we have wearable technologies that has been into loop these days, and we have remote imaging also as an emerging trends, offering convenience and accessibility to both the healthcare professionals and the patients. And as we have already, Dr. Ruchika said in the panel discussion one on delayed earnest diagnosis, we have AI, machine learning, genomic sequencing, lab-on-chip technologies, and digital pathologies are also there. So, which will help us to have more specific on the diagnostic part, where we can have the patient safety and a faster and accurate diagnosis.
Thank you, Jennifer. It's you touched upon AI, and which is the new buzz in the town and in the world, and it seems to be simple, but it's complex yet complex, and it has also got interdependability with the humans also. So what we feed in AI is what we're going to be getting it out. So that's so we know I know you've been really up it around the country and seeing various systems. So I would like to understand, and in fact, you can apprise all of us who are attending this session about something which is something which we really need to as a healthcare. Two aspects which we need to understand is one is the concept of AI, even in the smaller towns. How can, with the simplest technology, this can be, inbuilt in, and also the role of a telemedicine. It's very important. So how this technology can be adopted and adapted with this improving the diagnosis. It's an important aspect. So your thoughts on this?
Thank you, Dr. Shweta. Thank you, CAHO, for giving me this opportunity. Happy World Patient Safety Day and Happy Engineers Day. So let's begin with artificial intelligence and machine learning. Artificial intelligence in particular has transformed the radiography by automating the analysis of images, detecting the clinical outcomes that may be overlooked by the normal human eye. Machine learning is basically, it's capable of extracting more complex and high-level data. Also, integration of AI into radiology reporting has structured and annotated to bolster report uniformity and streamlining the patient's history tracking, and also plays a pivotal role in maintaining the provider's communication, patient care, validating the correlations between imaging, diagnosis, reports. It also talks about the treatment plans, alerting for any discrepancies, etc. Now, coming back to the benefits, AI and ML are transforming the radiological department by improving the diagnostic accuracy, improving efficiency, and patient care. So if you look at the benefits, some of them include enhanced image analysis and reconstruction. Then we also talk about automated detection, increased speed, improved accuracy, decision support, data analysis, and even personalized medicine, because you can enable tailor-made treatment plans based on each individual patient's characteristic. But when you look at the real-world examples, some of them include Google's Lina, IBM's Watson Imaging, Siemens Healthineers AI-powered CT scanner, coming to GE's Healthcare's deep learning image analysis, etc., etc. Some of the real-world examples. But there are challenges and limitations too, because one is depending on the data quality and availability, the systems that we have. Two is the bias in the algorithm and validation. Three is regulatory frameworks could be a challenge when you want to go into full AI and ML. Same problem can happen because of integration with the existing systems that are in the hospital. Fourth one, the radiologist training and adoption. And finally, cybersecurity requirements and cybersecurity problems. So the synergy between a radiologist and AI or ML definitely will revolutionize the diagnostic accuracy, efficiency, and patient care. Coming back to telemedicine, in fact, if I go back to our stage in Rajagiri Hospital, even before the COVID system put us all into trouble. We had the system up and working, and it was very, very useful, basically because of the closeness that you come to with a patient, even though they are located so far away. The systems were well established, protocols were well set up in Rajagiri, and the systems were very much useful to the end users when it comes to telemedicine. Dr. Shweta, you are
Dr. Shweta, you're mute.
Sorry. So thank you, Vinod. Thank you for that insight. And Subin, this would be a good clue to take out, and understand there are some of the challenges which each one of the stakeholders face during.
In fact, before I take up the next session,
yes,
Dr. Tamangna Ghosh comes with a real life experience with AI because he's an AI expert in imaging. Would you want to take a minute on this, Dr. Tamangna?
Sure. Yes, sure. Dr. Ghosh, can you take us through some of the clinical decision support system where AI is inbuilt and your experience at it? So that would be helpful for our participants to understand.
So, I'll stick to the work that I do.
Yeah.
So I am part of this startup called Cure.ai. And, we are chipping away in the background, working to integrate AI into imaging and healthcare systems. And I'll talk about one of our largest success stories, actually. And I think that fits in really well into this context.
Yeah, better to have success stories because I can give you a failure story from.
No, then I'll touch upon the
connected with you.
Okay, please go ahead. We will handle that.
And then I'll touch upon some of the issues with AI as well. I mean, it's two sides of the same coin. But for example, I think
PCR नहीं लगाना ना फिर.
Just a second.
Rabina, can you mute others?
Rabina, can you unmute the participant? Dr. Ruchi? Dr. Ruchi?
उन्होंने कहा था तो suspect
Please go ahead.
Yeah. So, for example,
host can mute people, right? Host, just tell the host to mute.
Yeah, that's what Rabina, we asked Rabina. She has host. Mute. Go ahead, Dr. Ghosh.
Right. So, until say, 5-7 years back, or like at least a decade back, I think at least what we were taught is that screening of tuberculosis is done based on, doing like mass sputum sampling and then maybe like fluorescent microscopy or, maybe now there's gene expert, etc. And when it comes to like public health and doing, mass surveillance or, mass kind of screening, it is a lot of cost to the healthcare sector. And that's why we have been able to bring in AI, and it does, a single thing very, very well, which is just identify signs of tuberculosis on chest X-ray. Right. And how does that help? That has completely changed the screening pathway. Now, instead of asking for, say, sputum sample collection and then, using fluorescent microscopy or gene expert where they're spending around $10 per kit, you can have mass screening just on, X-ray with the AI kind of reading and giving a score, a probability score of how likely it is that there is tuberculosis. And then those who have, a score beyond a certain threshold are evaluated with tuberculosis. So, where does AI shine? AI, I think, shines. I don't agree with the fact that, it's going to replace a radiologist or a pathologist because, we have a different set of skills and we bring in a lot of versatility. Yep. While AI functions really well when it is, directed towards one single problem. So in an example like this, the advantage of an AI is that it is working 24/7. It does not get tired. It doesn't matter if it's 1 X-ray or 100 X-rays or 1,000 X-rays. It's going to work the same way. It doesn't matter if it's night or daytime, right? Or over the weekends. So that is where AI can act like a second pair of eyes, which is working in the background whenever, there is a potential mistake happening or whenever there is a chance that a radiologist is overworked or, they're having tunnel vision or getting distracted. This works in the background, acting as a safety net, just reiterating that, yes, you've made correct, you've made a correct decision, or you've at least highlighted certain, the AI will highlight certain portions where it thinks you should kind of put your attention to and say yes or no to its diagnosis. Of course, this in no way kind of replaces the role of communication or the role of having good processes and a good culture within the diagnostic setup or within the hospital. So patient safety cannot come just from AI, but AI being implemented well in a culture, which is fostering, efforts to reduce error rates and improve accuracy in diagnosis will definitely help.
Yeah, thank you. Thanks,
Thanks.
Dr.
Thanks. Yeah, thanks, Dr. Tamangna. Moving on to the second part of the panel discussion, I would like request her. I'll put my question across to Dr. Rima. This is a very basic issue. I don't want technical answer, Dr. Rima. I don't want the quality QC, IQC, CAS, and all that stuff. I want what are the challenges that we face in the laboratory in terms of minimizing? How do we face those challenges in terms of minimizing the diagnostic errors? And what are the solutions that have been successful that you may be aware of?
Thank you, Dr. Suvin. Suvin, as you rightly said, because all that is very much known, the pre-analytical burden and the analytical issues and the post-analytical issues, because we all are from the diagnostic background. But one thing, a famous poet said, T.S. Eliot, I like to quote, most of the evil in this world is done by people with good intentions. And, we all are responsible people working in the lab. We want to give the best result, but still there are challenges. And I'm happy that the new ISO 2022 has brought in the concept of risk. There is so much of risk involved in every step, right from the beginning till the end, even when the test was not even ordered. The test was, the patient was yet to get prepared for giving the test. So we need to identify the risk at every level. I'll share a small story with you. My experience when I was working in a hospital, the medical director of our hospital was a surgeon. He gave a sample, he was a diabetic. He gave a sample for, a routine check. And because it's a VIP sample, so we sent our trained phlebotomist to collect the sample, who was that day posted in the phlebotomy room. So he went and collected the sample, and the report was checked, everything was checked, and the report was given. And I got a call from Sir's wife, because he was there in the surgery. And before that, the report went to her. And she called that, how come the potassium is high? I was surprised. And we looked at, every aspect of pre-analytical to analytical to post-analytical to any instrument errors or things like that. And everything was found okay. And later on, when I investigated, called who collected the blood sample, how it was collected, where do you went, and what did you do? He said, I went to his room and I did this procedure. And how he tied the tourniquet. And when I investigated, how long did you tie the tourniquet? And what did you do? Can you demonstrate it? I actually had to dig down to that level to find out the cause of potassium in that sample, because the sample was absolutely clear and clean. It was a neat sample. There was no issue of integrity of the sample getting compromised. And it was done on a priority because it was the sample of a medical director. It had to be given that VIP, priority. So then I simply apologized and I just requested another sample, fresh sample, because I had one doubt whether there was some error or issue in collection of the sample technique used by the phlebotomist. So I sent another, my technician who was in the organization for long. She had worked there for 20 years and she was very well acquainted to the medical director and the teachers there. So she collected the sample and the potassium came absolutely normal. So what happened? We could identify that it was due to the microhemolysis caused during collection. So the point here is that sometimes there is invisible errors can happen in the laboratory, which can lead to a misleading diagnosis. Fortunately, there was a good rapport, so there was not much of a hue and cry, and it was in the house. But consider this report going outside, because having worked in, a chain of laboratories where the sample is collected in some remote areas, it travels across the city, states, and reaches by air, road, and things like that. What all it undergoes, we don't know. So, there is a lot of challenge in every step. So I think my, learnings in all these years is completely aligned with the risk. So I think we need to see beyond what we know. We need to learn beyond what we know. We need to identify the risks at every step, what can go wrong and the possibilities of how they can go wrong, and then to put up a system to mitigate it. I think that will, help us evaluate and still be open to learn from the mistakes which can happen.
Absolutely, Dr. Rima. In fact, just to elaborate, just more couple of statements I'd like to tell from what you said. The example that you gave was very good. The way you handled it was very good, because that's how it is to be done. Any result that comes from, say, the analyzer, or any result that comes with us should not be brushed under the carpet. There is a reason. There is a scientific reason for it. I'll give you an example. Low platelet count on a absolutely normal patient. If you look at the smear, sometimes you can find out, these platelets have got aggregated with the, say, the neutrophil. We call it as a neutrophil, EDTA-induced thrombocytopenia. But at the face of it, you may find there's an aberration by the analyzer, but it's not so. There's a science behind it. In EDTA was inducing. In your case, there was a microhemolysis that was occurring. So unless we deep dive, understand the science behind why the results have come out, so the learning process cannot be stopped abruptly by saying, these things, okay, we'll collect another sample, or we'll do another image, or possibly our analyzer was wrong. No, there is a reason behind it, and that is what should be one of the key takeaway, that learning from whatever results that come out to us is important, and we take it from there.
Okay.
Over to you, Dr. Shweta. Thanks, Dr.
Thanks, Subin and Rima. That's what we are. It's a good discussion where we going and deep diving into the root cause of how we can improve diagnosis. So I would move on to Jennifer. Jennifer, I can see you. Yeah, hi. So Jennifer, how do we foresee, the point of care testing is coming up, it's in a big way. And earlier there used to be very few tests which were considered as point of care testings. Now there has been a huge list where this helps the clinicians for, quick diagnosis, and that also helps us in treating the patients timely. But there is a challenge with the point of care testing with respect to, again, the clue from the previous discussion, wherein how we can improve diagnosis using the point of care testings, and what role does the technology and the equipments used for point of care testings would help you. So what's your, key takeaways from this?
Yes, ma'am. So actually, point of care testing is given where patient is being treated remotely or near the bedside, right? So increasing your use of point of care testing has reduced increase the rapid turnaround time and generating the quick results, and implementing appropriate treatments also. So comparatively to the traditional time-consuming setup, here we go in hand into the patient area. We test it and we generated the results then and there, so that we can send the results or see the reports with the help of IoTs, AI, and mobile computing. And the doctors or the clinical team who has been in remote also can contact the healthcare professional who's there on site with the help of telemedicine, and live diagnosis can be made. And recently we have developments of mobile integrated handled ultrasound scanners, handled radio X-ray units, and mobile MRI units, and even the fetal monitoring is also now can be done remotely with the help of wireless access. So this is how the technology has improved, ma'am, with in case of point of care testing. And all the technological advancements and miniaturization of the electronics and improved instrumentation has revolutionized the POCT recently.
Thanks, Jennifer. And the role of QCs are also very important. The validation test when we run through for each POCTs is it's a very important aspect. Subin, would you like to take up the next panelist? You are muted. Subin, you are muted.
I'll go to Dr. Ghosh. Dr. Ghosh, in laboratory, possibly most of the tests that we come to us, apart from say micro and to a greater extent histopath, I not say all, but quite a few of the tests we may possibly not require clinical details. But in imaging, in radiology per se, I think it's the other way, because most of the the images, most of the procedures, most of the interpretation that you'd like to, you would need clinical inputs. So how, as a radiologist, how do you propose, or what is your strategy to improve the collaboration with clinical colleagues?
Right. That's a wonderful question. And I think the difference between and sometimes it's not appreciated. I think radiology still remains like very, very subjective. It's an interpreter's subjective, opinion on literally some shadows, right? And we are trying to look at the scan and think of the patient. And that's why the other perspective, or the other side of the coin, is that the clinician who's looking at the patient and thinking about the diagnosis or the scan, we need to put two and two together. So I think some of these strategies, are very simple, but they're very effective and are, definitely doable. And some of it are like more technology based, and I think we will slowly kind of adapt to it. So, strategies like, for example, double reading, like very simple. It's just having two, independent radiologists interpreting the same set of images. And, this simple practice can actually catch a lot of discrepancies and reduce the diagnostic errors. And this is really helpful in extremely subjective or highly variable tests like mammography. And we've seen the double reading of mammography really reduces the chances of, unnecessary investigation with MRI, doing breast biopsy when it's not required, etc. And also having like a peer review system. And sometimes it's very difficult to do if you are in a teleradiology setup, or you are just the only radiologist in a center. But if you happen to be in a hospital setting, or you have peers who are working with you, or in an academic institution, definitely, colleagues reviewing a set sample of previously interpreted cases and then assessing the accuracy, and wherever there might be mistakes or difference in opinion, providing that feedback. I think that continuous loop can definitely help, right? So yeah, these I think this would actually encourage more clinicians, questioning more clinicians, having that information to come in. I think definitely, right? And apart from that, I think also, the boon or the bane of technology is that today radiologists have that flexibility to be able to sit anywhere in the world and report, right? I have the flexibility to be on the move and report as well.
Yeah.
That also means that we are sequestering ourselves away from the clinical
Absolutely.
work. And there's
Absolutely.
no denying that as well, right? So getting ourselves more involved in the discussion, right? Picking up the phone. There are so many means of communication today, be it WhatsApp, be it just picking up the phone, or actually walking in and having an in-person chat. I think that fosters a culture or building of relationship between the clinician and the radiologist, and that really encourages them to provide more information to us, I think. And similarly, whenever we have a report, I think requesting the clinician or asking the clinician for feedback, that based on our provisional diagnosis or what our hunch was it acted upon? Did it turn out to be true? Did it actually make an impact on the patient? And that coming back to us also helps us make better reports. Yep. I think.
I think you
That's
answered.
wonderful. That's
You
wonderful,
answered.
Dr. Ghosh. And
You answered our query very well, Dr. Tamanna. The one word sequestration that you use, that is really prevalent with our practice right now, and that needs to change, because what is happening is that there's a disconnect between the clinical team and possibly the radiologist or the laboratorian who do not have the working dialogue that is happening, and that is one of the major reason for diagnostic error, I should say. That's a challenge to us. Also, second part, which I liked what you talked about at the end of your statement, was about learning from the feedbacks. That is also very important. I mean, generally what happens is that most of us sign it off, our report or result, and we think that our work is done, but not knowing the feedback, the clinical feedback is what is the final stamp on the our accuracy, whether we did it right, our job right or not. And That is where the learning from those issues come, and the feedback loop should be completed only when you discuss with your clinical team. Thanks, Dr. Kam. Over to you, Dr. Shweta.
Yeah, so that's very important that the reports also have an impact on how do we write a report, or how do we, diagnose, and it should be actionable interpretations, right? So basically, how the patient even, I was involved in a panel discussion with the clinicians yesterday, and there was a, a good amount of discussion around how does get patient involved in their diagnosis, and when they get a report, maybe a lab report or a radiology report, how do they interpret? So maybe there is a gap here, and which we need to really think about how we can bridge that gap and ensure that we have some system developed. Maybe we as CAHO can take that lead of ensuring that we can, try, bridging, identifying that gap of, I can see Nadira ma'am is also here. I did see her. So she is also part of Patient for Patient Safety Foundation. So that is one important aspect which is also missed here, is that how is the patient involved, patient communication, in ensuring that we don't miss a diagnosis or we don't interpret wrong, and how is this patient understanding? Maybe they is collecting a report and going somewhere else. So maybe so how is the reports being written? So probably that's a way we need to go further. Coming on to I would like to ask Vinod. And again, it's Vinod, it's all our discussion with you involves around how we ensure that the systems are safe for the teams to work in a safer environment, whether it's laboratory, whether it's radiology or any other equipments, right? So I would appreciate if you can apprise our, the participants about how safety, contributes, the equipment safety handling or the equipment handling contributes towards improving diagnosis for patient safety. So over to you, Vinod.
Yeah, thank you, Dr. Shweta. Let me come to the radiology department and how quality imaging and minimizing radiation becomes a risk, how the radiation safety is going to be important in the radiology department. Radiation doses generally are of different modalities. And as you know that we have from X-ray, CT, PET, CT, cath lab, etc. But how much longer the radiation exposure needs to be and what kind of energy level the radiation has to go through, it all depends on many factors. So it's important to actually optimize, to obtain an optimal image quality at the same time to reduce the radiation exposure. So we need to make important decisions into having certain site-related protocols. It depends on the site of the person. For example, if it's in the pelvic zone, the exposure is larger as compared to the neck zone where it is going to be of lesser exposure. Similarly, it depends on the anatomy of the patient. Suppose if it's a fat person, the exposure levels are high. When it comes to a pediatric patient, the exposure levels are low. So here, what happens is the usage by varying the kV, kilovolt, and milliamperage sets the different levels of radiation energy levels across to the patient. Accordingly, the exposure levels can be set across. So radiation safety becomes very important. So the following few strategies may be looked at when it comes to radiation safety. One is using optimization techniques. Second is using technological advancement, following the safety practices, complying with the regulatory complying with regulations and statutory requirements, patient-specific approaches, and using quality improvement tools, staff education and training, like what Dr. Ghosh said. You need to take feedbacks and convert them into good usage so that your safety becomes very important. When it comes to optimization techniques, you can consider 3 types. One is a protocol optimization. Second is dose reduction algorithms can be used. Third is automatic exposure control so that you can adjust the radiation dose based on the patient size and the anatomy of the patient. Coming to radiation safety practices, we know that we all use ALARA. We can also consider radiation monitoring and tracking, have specific patient specific dose calculations always considered in the safety practice. Go for proper staff training on radiation safety. and include quality control and quality assurance programs across the radiation department. Next important one is patient-specific approach. What are the kinds of patient-specific approach that can be considered when it comes to patient safety? One is have specific protocols for the different kinds of patients. Have personalized dose adjustment based on patient size and the patient's medical history. Also look at the informed consent and patient education. All these becomes specifically with reference to the patient-specific approaches. Another important aspect which I touched upon earlier is about the staff education and training. We need to conduct safety trainings, workshops and conferences, online courses, webinars, interdisciplinary collaborations, basically to make sure that everybody connected with radiation are all going to be in the safe zone at all points of time. And as important as it, like in safe quality improvement initiatives have to be considered at all points of time to have a process of monitoring and analyzing our radiation doses, tracking the image quality and diagnostic accuracy, conduct patient satisfaction surveys, and also implement the changes that you want to based on the feedback that you get and based on the data analysis that we do that. So by implementing all these strategies, I think our departments can minimize the risk to radiation, at the same time maintaining high level of good quality imaging. And as such, in any part of the hospital, I think we need to bring in induction trainings as well as refresher trainings in compliance with regulatory requirements and in compliance with the safety guidelines for the radiation safety. I think I'm done. If any more doubts.
No, thank you. Thanks, Vinod, and thank you all the panelists for giving all those insights and some triggers for us for our some brain stimulators. So we need to go back and deep dive into some of the aspects which are really upcoming, whether it's innovations, technology, communication is very important, the key aspect to bridge all of us together. And it's very important that we involve patient. And thank you all for joining in. And we take this opportunity. Suvin and I had a wonderful time, moderating this session. And in between, we forgot that we were moderators and we were part of the discussion. So that's the beauty. That's the beauty of having a very effective discussion, that you get involved as being passionate into patient safety for patient safety, and we all think alike, and that passion should brew more. Over to you, Suvin, for the last remarks, and we hand over to Dr. Aparna later on for the next session.
Thanks, Dr. Shweta, for co-hosting this particular panel discussion with me. I thank Dr. Ghosh, Dr. Rima, Dr. Jennifer, as well as Vinod Bhai for helping us conduct this particular panel discussion and giving lots of insights about diagnostic safety with respect to whether you're a diagnostician or you're an engineer. From diagnosticians, if I can label both lab as well as radiology together, the most important insight I understand is getting a collaborative communication in place with the clinical team per se, most importantly. Patient engagement, as Dr. Shweta madam rightly put up, I think that is one area which possibly will get covered in the next panel discussion. Let's wait for that. Because that patient engagement is that missing link right now in our entire diagnostic process, because we generally don't have that space or time for engaging the patients as of now. And Jennifer and Vinod for sharing the various aspects of equipment, the AI, the radiation and technological safety per se, which possibly affects both the staffs, the doctors, as well as the patients, and which are needed to be taken into account when we talk about diagnostic safety as a whole. Thanks, everyone. And from both Dr. Shweta and my side, I'll request Dr. Aparna and Dr. Joy sir to take over the next panel. We hand it over to you, sir.
Thank you, Dr.
So-
Suvan and Dr. Shweta. Thank you so much.
Thank you. Thanks.
Yeah, so I think great work by both the moderators. This is how actually we had envisioned this super work. Now I'm filling the blanks and filling in for Dr. Anuradha Pichumani. Uh, uh, it's about patient engagement, and we are going to hear it from our patients. We have got two of our uh, patients, one from Delhi and one from South, who are going to share. But before I move ahead, when we were inaugurating, we missed Dr. Vijay Agarwal sir and Dr. our dear Lalu madam, who are now in the call. And thank you, sir, for and LJ for motivating us to have this, make this program. And I'm sure we really missed you during the inauguration. So thank you, sir, and thank you, ma'am. Can I have my co-moderator, Joy?
Hi,
Joy
Dr.
Chakravarti.
Yeah,
Hi, hi.
Dr. Aparna, I'm here. And as you have set the tone, I suggest you that you first go ahead with the patients and let us hear what they think and what they feel is the need of the hour. And then we'll go to expert to talk about that how we can involve patient in terms of getting and developing patient safety. So pleasure to
Thank
be here. And I think one of the interesting session we're going to start.
Yes, sir. So thank you, Mr. Joy. And now we will have we'll hear from two of our patients who have graciously accepted the invitation to share their experience on patient safety. And so I have Mr. Ajit Kumar. He is from Kerala, Cochin. He works with one of the media companies, and he's the executive director. Ajit, can we hear from you? Okay. Yes. Ajit, are you there? Okay. Jyotsna.
Good afternoon, everyone.
Yeah, thank you. Over to you, Jyotsna. I'll connect Ajit after you.
Thank you so much, Dr. Aparna Jairam, and good afternoon to the esteemed gathering present here today. I feel extremely humbled to share my perspective on this crucial topic, patient engagement in patient safety. What I understand that it is not just a buzzword. It's a cornerstone of quality healthcare. Good communication between clinicians and diagnostic consultants brings down the stress and anxiety of patients. I'm talking from the point of view of a patient. And to begin with, allow me to take you through the most troubled period when I was a patient navigating a complex medical journey. The experience was challenging, to say the least. I was in an isolation ward. Will to live was non-existent. Breathing was dependent on the big mask on the face. Speaking was labored. And most of the communication was through gestures. For the first time in my life, I found myself surrounded by strange faces, kind eyes, but encouraging words from Dr. Gogia and his team in Sir Gangaram Hospital. It was the compassionate care and open communication from my healthcare providers that made a significant difference. One of the most heartwarming moments of my hospital stay occurred after I was shifted to a private room and I was on my path to recovery. I was giving my sister a gold earring and mentioning that I had lost one of it during the early days of my illness. This earring held a great sentimental value as it was a gift from my departed mother. Dr. Mamta Kankra overheard the conversation and immediately contacted the nursing head of the COVID ward. Despite the passage of time, Dr. Mamta's call led to a remarkable discovery. The earring was found lodged in the wheels of the bed I had been assigned. It was incredible and speaks volumes about the ecosystem of compassion and patient-centered care provided by the hospital staff. Their dedication to finding my lost earring, even after a week had passed, demonstrates their commitment to ensuring the well-being of their patients. Coming back to the topic, while I might not have been in a position to actively participate in any decision during my illness, I firmly believe that empowered patients can make a profound impact on their healthcare outcomes. When patients understand their condition, treatment options, and potential risks, they can make more informed choices. Engaged patients are better equipped to identify and report adverse events promptly, contributing to improved safety and care. Moreover, open dialogue between patients and healthcare providers promotes trust and collaboration, leading to better outcomes. To strengthen patient engagement, a healthcare environment must be created where patients feel empowered to ask questions, participate in decision-making, and access their medical information. Prompt availability of diagnostic results and availability of diagnostic consultants to report and give advisory in the results is also very helpful. By involving patients and their families in their care, patient satisfaction can be improved, adherence to treatment plans can be ensured, and overall healthcare experience can be enhanced. I've witnessed the power of a strong doctor-patient relationship firsthand. Going back in time, my grandmother's doctor was a renowned heart specialist, Dr. R.K. Agarwal. He went beyond the call of duty. As years passed and frequency of his visits increased, my grandparents and Dr. Sahab became so fond of each other that from calling them Mr. and Mrs. Lal, he started addressing them as Amma and Baba. He would sit with my grandparents for extra few minutes to sip a hot cup of coffee. And this was so therapeutic for them. My dadi would be excited on the days that he had to come. She would forget that all about her breathing problems and would make sure that his favorite kebabs were ready for him. Their bond was more than just professional. It was an example of human connection that can enhance the healing process. Without taking much more time, I conclude and I quote the renowned physician and author, Mr. William Osler, who once said that the most important thing in medicine is to treat the patient as a person and not as a case. By embracing patient engagement in patient safety, we can create a healthcare system that truly centers around the individual and their unique needs. Thank you all for giving me this opportunity to put in my perspective. God bless us all. Thank you, Dr. Jairam. And thank you everybody on the panel.
I think thank you, Mamta, for putting me across to you. And it was really right from your heart, and we really appreciate it. We have got Ajit Kumar back. Ajit is celebrating Onam in Kerala, and he's sparing few minutes for our, actually patient engagement. So Ajit, if you can share your experience.
Hi, good afternoon, Dr. Aparna, and all the audience out here. Basically, I want to narrate a story of one of my family members who has been, suffering from allergic condition. So she had a condition wherein whatever she eats, soon after eating any food, rashes will appear, and she has been suffering this from the age of 13. So we had taken her to a lot of doctors, in fact, across many cities in Kerala, also out of Kerala, like cities like Bangalore. We met a lot of specialist doctors. So we also approached Ayurveda and homeopathic doctors, because it has been for ages. There was no answer to this condition. So every time this continues, and after taking some medicine, it goes away. So finally, I happened to meet Dr. Aparna Jairam through a friend of mine, and I was narrating this condition to her. And she asked us to undergo some blood tests and told us that it may not be allergic, it can be something else. So we did the test, and surprisingly, we came to know that it is gluten sensitivity, the cause for the particular condition. And then she suggested us to consult a gastroenterologist. So we did some more investigation. And yeah, finally avoiding gluten, now the condition, is resolved, or now the patient is happy. So it is very critical. I feel it is one of the very key thing for any disease like this is the proper diagnostic and understanding of the condition. That's what I can share about the importance of proper diagnostic and the contribution of pathology in this disease diagnostic and solution.
So thank you very much, Ajit and Jyotsna. We really appreciate you coming up, both of you, and sharing your experience. Over to my colleague, Mr. Joy. Can you take over from here for our next presentation?
Thank you, Dr. Aparna. And I think it is very nicely crafted session where very rarely you can see a patient who is the center of our all activities has been brought into the picture, and we are directly hearing out from them. Maybe we have listened to 2 patients, but we have several millions of them around us. And all of us, we need to hear out them, and we need to see how we can engage. Now it is my pleasure to introduce Ms. Nadira Chaturvedi, the co-chair for Patient Safety Foundation, and also a social entrepreneur, apart from many other identities, many other positions she holds. So welcome Ms. Nadira in this session, and I think under her leadership, the CAHO has worked tremendously on engaging patients to improve patient safety, and we're going to hear some of those from her. Keeping the topic of this session in mind, that is on diagnostics part of it. So the first question what I'm going to ask Ms. Nadira is, what is the role of diagnosis in patient journey and health outcome? All of us we know, but we want to see and hear any new dimension if it comes out. Over to Ms. Nadira.
Thank you, everybody in CAHO, for giving us this platform. 2 years ago, I wouldn't have dreamt that we'd be part of this presentation as patients, as caregivers. When we entered this field, thanks to Dr. Agrawal and Dr. Lalu, it was just a different impression. We had apprehensions, we had biases like all people, and we were wondering what you all do and what we do. There was a we and there was a you. It still remains a we and a you, which we want to bridge. That's the first thing we want to say. But before I answer, and thank you for the introduction, Dr. Joy, before I answer your question, I would like to present my story as a patient, as a caregiver, not as a patient, but as a caregiver, if I have the permission. Sure. Dr. Jairam, do I have the permission to go ahead with that?
Yeah, go ahead. Go ahead.
Okay, this is a real story. Again, thank you, Jyotsna, for giving a wonderful picture of patient centricity, and Dr. Ajit for diagnostic inputs. I'm going to give an adverse event. I dare to bear myself, and I bring out another aspect of this whole picture. We do not talk of adverse events freely, but I think I have the responsibility, and not just the right, to present a perception of an adverse event. I repeat, and I want to qualify this statement of mine before I begin all the sessions in the morning and the previous one, because I heard that more attentively. was amazing, the work you all do, and this reiterates our impression of all the doctors, nurses, clinicians, physiotherapists, diagnostic, all of you guys are doing so much for us, but we don't know that you are doing it for us. So there is no doubt about your dedication, your intention, but still, as Dr. Joy mentioned, one piece is missing, and that's us. As a patient, you're doing it for us, but you're not doing it with us. And to me, Patient Safety Foundation is trying to bridge that gap. We'll come to it at the end, how we're doing it. But just to cut a long story short, 4 years ago, somebody very, very dear to me had a bad experience, and he was discovered. Okay, let me give the history first. For 2 years, this person was suffering from dental problems, oral health, pain, ulcerations, inflammations, and it's a family history of having dental problems. All the siblings have it. But he was in touch with a dentist for 15 years. I repeat, 15 years is a long enough time to know somebody thoroughly. All they did was remove implants, put some root canals, things like that. About 8 months before his diagnosis of carcinoma left lower alveolus, in a very advanced stage, he had been put 3 implants, which did not sit well, and the pain intensified. We complained to the doctor. They removed it reluctantly, one by one, and they said there's erosion in the gums, there's erosion in the bones, and that's why the implants are not taking root. They just gave us mouth pain, they gave us painkillers, antibiotics. The symptoms did not go away. So we were dissatisfied. We shifted ships. We went to another doctor, another dentist. He did something, CBDB, some X-ray which had about 100 images. He also could not identify anything. So we shifted again. Maybe we were wrong in shifting gears, but we went to a couple who was a teaching couple, a dentistry teaching couple, professors. And we were in their hands for 3 months, 4 months. They again did the same, adding more, extracting teeth, removing dentures, doing everything except doing the right tests. All their tests, all the diagnosis tests were related to X-rays, open mouth, closed mouth, all that kind of stuff. Dr. Rima mentioned how a test is taken. Brilliant. Dr. Ghosh mentioned why a test is taken. Also brilliant. He mentioned about the communication between the clinician and the diagnostic team to explain why that test has to be taken. Absolutely right. But even then, something was completely missing. Who decides the tests? Which tests to be taken? Who decides to shift gears? Why didn't somebody think of going beyond dentistry, beyond at this particular ailment and looking for more answers, because the patient continued to inform the symptoms. There was no negligence there. There was a continuation. The point of care was limited. The specialty became myopia. The dangers of being super specialists is myopia. We do not think beyond our nose. And to me, that is a problem that the entire industry, the entire world has in any specialty. If it's a manufacturing, they look at manufacturing. They're marketing, they look at marketing. You know, there's a saying that we don't know anything, you start to teach. And if you can't teach, you manage. I think our professional background of managing teaches us that there may be more reasons than just what is visible. To me, that was mistake number 1 in this whole journey. It's a perception. I repeat. When after repeated problems, and it was mandatory to send a tissue for a biopsy, after 18 days, we get a WhatsApp message, saying that we are about to die, okay? So you don't break bad news like that. We went into panic mode. I've had 2 decades of experience with cancer. I'm a survivor myself with great experiences and interaction with several patients. So we had the connections of good doctors, good hospitals, and we jumped to the first one. Now, the irony of it, not just 3 doctors, the very morning we get this information, we had done a preventive health checkup. We did it regularly, religiously. And that morning, it was 8th of November, and we got the reports with 10 on 10, very well done remarks by the endocrinologist. My husband had diabetes. So we were happy, and he was healthy enough. But the doctors mistook his happiness, his stride for being a healthy person and did not look beyond. Maybe we were at mistake too. As a patient, as a caregiver, I should have known, I should have asked the doctor to check for more things. I was too busy being me, perhaps, and I was too trusting of the doctors and the system to not ask more questions. That's another mistake we make as patients, as caregivers. We don't dare. And today, thank you for giving me this opportunity. With all due respect, I'm just presenting a case so that we can all dare together to look beyond. So the clinicians, if you cannot understand, if the symptoms don't go away, should we look for more reasons? Should we look beyond our expertise? Look at the whole person, not just, and now I understand those two words, correlate with clinical something. You'll always write on a test report, to be correlated clinically. I understand that meaning now. I didn't understand it then. So maybe we are missing out. The whole game is, y'all are experts. I don't deny it. The expertise in taking it, how to take it, machines, AI, reporting, everything was great. But I think three things are missing here. And I'm going to divide it into 3 zones: before, during, and after. If I do not report my symptoms, how can you take a diagnostic test? How can you diagnose it? So I think we ourselves are at fault as patients, as people, because we do not take our symptoms seriously, and we do not report it in time, and we do not come to you earlier. Therefore, how can you diagnose? So that fault lies us, and we as a foundation are trying to make amends in that area. I'll just show you in the PPT that comes. During the treatment, during the point of care, when we are in your hands, I urge you, please have those teams together. You all mentioned, Dr. Ghosh mentioned doctor and clinician coordination. I really applaud that. Dr. Shweta mentioned appropriate tests. Let them be disappropriate as well. Let's go beyond and let's adventure into new tests. Thank you for those 2 sentences. And I go beyond. After my husband was treated, after it all failed, well, okay, the failure came in because we were in a hurry, we were vulnerable. We took the first decision of the doctors. We went into surgery, he was fit enough. We went into grafting, his femur was cut, grafted on top. The subsequent radiotherapy did not work because the bone graft interfered with the rays of the direction, and he got a recurrence within 6 days of the last radiotherapy. So his condition declined. We lived 6 months. I repeat, we lived 6 months. We did not die for each day of the 6 months. But at the end, the cancer took over and we lost the case. I think we went wrong in not taking a second opinion. I think we went wrong in putting the graft, but that's all hindsight. I salute the doctors for doing their best. I have no grouse. But I do have a bone of contention with the 3 dentists. I went back to them. And I'm coming now to beyond the point of care, which is aftercare. How many of us come back to you and tell you that we suffered? None of us come back. Not a good patient. How many of you seek us out to ask what happened? Prognosis, what happened? I went back to the first doctor. He pleaded amnesia. We don't have the records. I went back to the second doctor. He said, okay, leave your reports. I will see that I don't do it again. I don't know whether he was a one-man army. I went to the third doctor, the team, and they defied, they denied, they argued that we had showed you, you had given your consent forms, you had signed them. And so nobody learned from this mistake. This platform, I'm very, very grateful to all of you. And I just present this platform as a learning platform. No, I'm not here to cry. I'm not here to blame. I'm not here to claim. But I think as a patient, we learn. And as clinicians, as doctors, as diagnostics, let us all learn together to bring the patient, listen to the patient as a whole, and then do. It is like your diagnostics tests are like, it's like an ocean. And you get some fish. But what about the fish that escaped that net? We don't know it. And that's where we as a foundation, Varsha put on the PPT, that's where as a foundation, we are trying to do our bit, thanks to CAHO for giving us this promotion, by sensitizing people, by educating patients to come before, to learn the symptoms, to learn to report, to ask questions. Next, to ask questions. I mean, I don't have to repeat the causes, you've already done it, but missed and miss, they're 2 different words. Delay is as good as wrong. Wrong gives you other problems. There may be technical errors, there are communication errors, the pre-test, the post-test, all that is fine. But I think the bigger problem here is that which tests, when, and who will decide. To me, that is an area of concern. The consequences, keep moving, Varsha. The consequences are bigger because Varsha, can you move? The consequences, of course, extra suffering, extra cost. I mean, in even cancer, tuberculosis, they're so similar. We don't know. And we don't know the difference. Some people just lose, all the property in trying to do one. it leads to very, very dangerous parts. We agree there. So therefore, who is at fault? Next, who is at fault? We try to analyze this, and this is not just diagnosis. As a foundation, Dr. Joy, this is to answer your first question. As a foundation, we are trying to build a repertoire of simple, basic education material, which we have gathered all from the expertise of these people who are present here, from the global experts, from the subject matter experts. And really, when we analyzed it, we were more to blame, twice as much as the clinicians. We're all at fault. We are all human. But I think we are not addressing the green areas of medication errors, surgical missing. We are addressing the omissions by patients done during hospitalization, before and after, which means during our entire patient journey. And that's our role. That's how we are doing it. Keep going, Varsha, keep going faster. That's how our role, we are doing that. And we blame the doctors, but I think I would honestly, and this is a humble submission to all patients here, and you can tell all of us, but we admit we sometimes don't give you complete information, or we hide. If I'm bleeding and I may have cervical cancer, I don't want to say it. It's shame, stigma. Or we don't take the tests because we don't trust you. Or we think that you're only going to prescribe more and more, so we don't report to you. And everything, from skipping tests to skipping appointments, we end up with self-medication that causes bigger problems. So I think a lot of it is also us. This heat diagram and our journey, our patient, this is our GPS in the Patient Safety Foundation. We are not doing things from clinical perspective in the sense that we are never going to give clinical advice. That's for you to do. But we are doing it from the thought process that comes to my mind as a caregiver, as a normal person, as a fit or a healthy or unhealthy person, and as a patient. So the errors that we are trying to address begin before hospitalization, and they have a cascading effect on diagnosis, treatment options, medication, and including till the end. We may be better, we may not be better. This is the area that we are working on. How we are working on, I'll explain further. But at each of these stages, we firmly believe that if patients get involved, if we are alert, if we track our symptoms, if we follow your advice, if we keep our records properly, if we take second opinions, we might all benefit. And I repeat, humbly, I submit that our work is meant for the same people that you are treating, the same people that suffer, that same people that go into the metrics. But if we do not come to you, we're not even in the purview, and therefore we are not in the picture. I mean, your metrics of how many people died, how many people were saved, how much misdiagnosed is very, very limited to the people who came to you. What about the people who did not come to you? That is the area that our foundation is working on. And that is why I think whatever we've done in the last 2 years, we've touched about 20 lakh people already. Next slide is coming out useful. And this is the backbone of our work. We are collating, aggregating, not creating, symptoms for early detection. We highlight the risks, the causes, and the consequences of harm if you do not report early. So we are encouraging our people to come to you, not taking them away. So please treat this as a partnership. I have no grouse with the healthcare industry. I salute you all. Hats off to you all. But we also give tips, actionable tips for self-protection. And I think I mentioned earlier, as a patient, as a caregiver, our role is not just covered in the rights and responsibility charter made by NABH. It's great, but we have a bigger role to play. And we do not charge. CAHO is promoting us. Everybody is vetting us. So to that extent, we are trustworthy. And I think this is going to get momentum. This was a thought. This was an idea 2 years ago, but it's getting brilliant. I just want to show you a few things that we do start in the diagnostic arena. It's a vast subject, what we're doing. There are many topics, but since today's today's theme is this, we are beginning by encouraging preventive health checkups. It is not a comprehensive list. It's an illustrative list. It's an initial level test. We're also saying, please take it. We have classmates, educated people. If I go to the doctor, if I take a PHC, I'm sure something will be wrong with me. Why find out? I went for a small surgery and I found out I was pre-diabetic. I went into overdrive and my readings are in control. I've seen the damage diabetes does closely. So I think this is a very valuable thing. We must ensure, and all of you, I urge you again and again, please use these materials for the same people that we are concerned about, patients. Engage us, listen to us, talk to us both ways. Next. Now, a stroke. Somebody mentioned you worked in stroke. I think Dr. Ghosh mentioned, or somebody mentioned before that. So, simple things like this. Be confused. Is it just nausea? Is it heat stroke? Or is it really a brain stroke? So when we show them this and they can remember, it's easy to understand. We're taking this on, large number of corporates have used this and successfully so. Next. So we are trying to create illustrative visuals. We'll also have text versions. We have videos. It's all available on our website. We're sending them by mass mailers, by social media, by WhatsApps. Now, heart attack versus heart failure. One of them crept upon you slowly. We ignored it. The other one came as an emergency. Agreed, you had an emergency. So what do you do in an emergency? If you had the list of hospitals with an MRI, with a heart center, if you call 108 early, or if you knew CPR, maybe you would save the patient. But if a heart failure comes in gradually, 5 months, 4 months, 6, you have arrhythmia, you have fatigue, you have chest pain, you have dizziness. Should we not look at it? So this is our work. This is our offering to the patients. And this is up all of you. We have to listen to our body, which we don't. Next. So women's troubles. There's so much that happens in the women's area. Half the population is women. Different ages, different problems, different highlights. We have the body talks again. Excessive bleeding, frequent pain, chest pain, discomfort, change in the breast figures. We all ignore it. We're shy. We're afraid. I think just having that awareness, we will go faster. Next. So these are many of the things. Jump to the last ones. Here we'll go. So at the imaging, I think you all talked about imaging, and these are the varieties that we're also training them of variability. So even measuring, we keep going, jump to the last. So all these are kinds of things that we are doing. This is just examples. But for improving us, for engaging us, we have just 2 requests. Please communicate with us why you're taking the test, what it will give us, the reasons, and remind us. Of course, you have your own tools. I don't have to, this was done before the seminar, before this webinar. I am going to skip all these things. You've already got many more tools in hand. So Varsha, please skip this slide. All I ask from this is, but for patients, yes, providing full information, keeping track of your tests and doing a follow-up. Don't think just because the test report is good, you don't follow up, and ask questions. We are urging you all to do this. This is what I mean by patient engagement. Next. In fact, as we speak now, we have, next one, we had a great news for you. Dr. Agarwal is here. Dr. Agarwal, would you like to say what you just released, or shall I take the liberty of announcing it? I think I'll give it to you to announce that. Dr. Agarwal, would you like to come and announce the white paper? Varsha, next. Varsha, move. So improving is a two-way process. It's a collaborative thing. We have just released a paper on engaging patients to enhance patient safety, which is a comprehensive approach in Bhubaneswar. Dr. Gyani, the KIMS chairman, and Lalu ma'am and Vijay sir have just released it on the occasion of World Patient Safety Day. Please take a screenshot. This gives you the entire care pathway, the touch points, where you can listen to us, where you can talk to us, and where you can promote safety before, during, and after we come to you, not just in the hospital zone. So please help us to help ourselves. We help to each other. Next one, just shift to the last one. So we have our materials here, last slide. So please, this is the advice to patients: get involved, become aware, ask questions. And to you all, don't just treat us, please reach us and teach us. We are not done. This is where our material is kept. Our entire mission is to encourage people to come forward and participate in healthcare with the adage, my health, my responsibility. And that's what we are doing. And I hope that people, you can close it. You can close it. We do not want to take up more time. Thank you for giving us this forum. Thank you for giving us this opportunity. We are here. Please listen to us. Please teach us. Thank you, Dr. Chan.
Thank you, Ms. Nadira. It is, I must say, you started with the story, which is, I was very sad to hear that. And I think that has given us enough a momentum to move into these directions. And today I can see the kind of work your foundation is doing along with similar-minded organization. It is awesome. Only thing I feel in this country, when we have 40, 50% people who may not have access to this kind of materials, who may not reach out to a structured healthcare provider, how they will take care of that. I think that is something what we need to think and dwell upon. Your guidance, your future roadmaps, your tools, whatever has been shared here, it is very valuable to all of us, not only for the patients, I must say, administrators, providers, clinicians of this world. We must align ourselves with this kind of, tools, information to manage the next generation patients, next generation in a world where the people are going to be more demanding. People, they want to be part and parcel of the decision making. Otherwise, the kind of issues you have come across, that is likely to occur again and again. So thank you very much for sharing your thoughts and sharing the roadmap. I'll not take much time as we are running short of time. I'll hand over to my co-chairperson, Dr. Aparna Jairam. Over to Dr. Aparna.
Thank you, Doctor. We do have it in all the regional languages, by the way.
Thank you. Thank you. So, Dr. Aparna? Okay. So, with this, I conclude this session and I hand over to the Secretariat for the next session to begin. I think someone needs to unmute.
Rabina? I think so. Aparna is logged out, probably. Dr. Parag?
Rabina?
Dr. Atul?
Yeah, thank you very much, Joy, for that crisp session. I think, Dr. Shweta, we are on to the last,
Absolutely.
the last leg before we hand over for the vote of thanks. We are all ready for this tumultuous. We had a very, very, very busy contest, and I'd like to put on record our appreciation for all the zonal chairpersons as well as the state presidents who participated. Dr. Shweta, Dr. Atul, Dr. Jeet, Dr. Ranjit, and all of the state presidents who participated. We had 3 major events. We had the national level quiz, we had the best catch, and we had the poster presentation.
So I have a presentation to make.
So Dr. Shweta will now take over from here. Dr. Shweta, we are all here with you. Please, over to you.
Yes, thank you. Thank you, Dr. Parag and Dr. Atul and CAHO leadership. Good afternoon, Father Johnson. Good to see you. I've been there. So just allow me to share a presentation, short presentation. I know various participants are waiting eagerly to know the winners and where are they. I would just, any one of you just confirm to me that is the slide visible.
Yes, visible.
Yes. Thank you. Thank you very much. And I would just take a very short overview that how did we go about it, organizing this World Patient Safety Day competitions. And with me, there was a team. We all worked together, strategizing that how to engage our audience to in this competition for improving diagnosis for patient safety. So we outlined 3 competitions. The first was a national level quiz competition, Kaun Banega Patient Safety Gyanpati. There were 3 levels to it. The first level was Patient Safety Warriors. The second level was Patient Safety Champions. And the third level was the Patient Safety Gyanpati. We had total number of team participants were 126 teams who participated. And the theme was improving diagnosis for patient safety. So we went online, releasing the quiz, first level quiz questionnaire, and the teams, there were 3 in number, 3 participants in 1 each team from various hospitals. And out of the winners of the level 1 qualifiers, there were 15 teams who qualified as patient safety warriors. And it's a commendable achievement. It's heartening to see that so much of enthusiasm, and there were neck-to-neck competitions. We had a tough time selecting the teams, the 15 teams who participated, and they would be getting Amazon gift vouchers shortly to be released to their accounts. Then these 15 teams, we had the live quiz competition using a Kahoot, and this was a level 2, which was patient safety champions, which the quiz masters were Dr. Nihar Bhatia and Dr. Shashila Kavre. They are the state chairs for Rajasthan and Maharashtra respectively. So all these 15 teams, we had a very engaging and interesting Kahoot session, and the teams participated well. And out of these, in the level 2, the 5 teams qualified to level 3. So these were the 5 teams who qualified, and the rest of they would have a consolation prize of Amazon gift vouchers. And then we played the last and very interesting with Dr. Parag and I, moderating and being the quiz master for this session, level 3. It was really interesting and engaging session where we had all these pro teams, the 5 teams. We had 3 winners out of this. So congratulations to all the 3. Now I would release Dr. Parag and Dr. Atul. We would release jointly from the CAHO behalf. We would release the certificates. The winner is for the Kaun Banega Patient Safety Gyanpati is they are getting an Amazon gift voucher of rupees 6,000, and this is a team PGIMR Chandigarh, where the 3 of them participated, Dr. Saru, Dr. Pankaj, and Dr. Muhammad. Congratulations and a big round of applause to you all. Moving on to the first runner-up was HMR Delhi, and Prati, Anisha, and Abhan. They are getting the first runner-up position, and with the Amazon gift voucher of 1,500. Congratulations to you all. Wonderful. And the third prize, the second runner-up, goes to B.M. Birla Heart Research Center, Kolkata. And Dr. Samir, Manisha, and Sonia were the participants. And big congratulations to you all. You are getting an Amazon gift voucher of rupees 750. So well done, teams. And this was, again, a very memorable sessions which we had. Moving on to the e-poster competitions, and we had 2 awards being categorized here. So there was a winner category and a runner-up category. And surprisingly, we had some very large number of international hospitals participating in this e-poster competition. So there were around 126 e-posters to be were registered. And our jury had a tough time, evaluating it. So, but nonetheless, we really congratulate the winner of the international section is Aster Sanath Hospital, Maria Fuyo Antonio. They are getting an Amazon gift voucher of 2,000. A big heartiest congratulations to you all for winning the e-poster international category. Then we had a national winner for e-poster, Dharamveer Bhalla, Sehgal Neo Hospital, New Delhi. Big shout out to Dr. Narain under your leadership. Wonderful team performance, and this is very commendable. The national winner of e-poster. Congratulations. And the first runner-up for national is B.M. Birla Heart Research Institute, where it was jointly presented by Ms. Mamta and Ms. Chanda Bandopadhyay. They won the second prize, the first runner-up position, and with the Amazon gift voucher. Now we move on to the zones. We have an East Zone winner, Ruby General Hospital, BG Jason. They were the winner for the e-poster in the East Zone. And the first runner-up in the East Zone is the CK Birla Hospital, CMRI. Vijaya Lakshmi A. Nair won the e-poster, first runner-up position. Congratulations. Then moving on to the West Zone, Dr. Anshika Das, Apollo Institute of Hospital Administration. They won the winner of the e-posters in the West Zone. We have Lekha Rakesh Bangar from Leelavati Hospital winning the first runner-up position for e-poster. Heartiest congratulations. I'm sure the reactions are coming up or not. So Dr. Parag and Dr. Atul, please encourage that we should have a big round of applauses, which we can't hear, but we can at least see them, the round of applauses. So,
please, everybody, give big round of applause for all the
yes,
participants and the
there's
winners.
a huge work has been gone by participating and encouraging them. Wonderful performance. From the North Zone, we have Dr. Neha Dhak from GBH American Hospital, Udaipur. They won the e-poster competition. And the first runner-up from North Zone is the IHMR Delhi, Dr. Kashish Mahajan, as a first runner-up. So big round of applause to you all. The South Zone, moving on to the South Zone, we have Adeline Rishona P from Bangalore Baptist Hospital, the winner of e-poster. Wonderful, very nice, commendable job. And AJ Institution of Hospital Management, Rinza Nazarine, for the first runner-up position. A big round of applause to you all. Great work. Moving on to the third competition is the Best Catch. This is the Patient Safety Award. We identified the winner at the national level and a zonal level. And the qualifying criteria was any acts which has, gone beyond their job scope to successfully detect and prevent the potential harms to patient. Again, wonderful submissions from various employees across the hospitals, across the region, and we have around 43 submissions for the Best Catch, and the winner for the national level is the Mission Hospital Sohini Chatterjee. She won the Best Catch award for the national level from Durgapur, West Bengal. A big round of applause. Great work, Sohini. We were really proud of your achievement. Then we had winner from the East Zone, Dipanjali Roy from Apollo Hospitals. She was a winner from the East Zone in the Best Catch category. From Nisha Sharma, Indus International Hospital, Mohali, Punjab, was a winner of Best Catch in the North Zone. In the West Zone is Vinci Sunil Thomas, Fortis Hospital, Mulund, Mumbai, Maharashtra, and a great work done by her. It was really commendable. And from the central, we have Ravi Kumar Yashoda Super Speciality Hospital qualifying as a winner for the Best Catch. And lastly, we have from the south, we have Lydia Neni from Kaveri Hospital winning the Best Catch Award, the Patient Safety Award. So thank you, a big thank you. And I can't finish off by saying a big shout out to each one of the jury members who took their time and evaluating, all these submissions in a very, very meticulous manner, and it was very objectively handled by the team leads. Thank you, everyone. And a big thank you for the prize sponsorship, Dr. Atul. Thank you very much. And lastly, I would take this opportunity to thank the young member in the CAHO Secretariat, Ms. Nisha, for her hard work which she has been put together to put up this, supported us in this particular competitions, organizing these competitions. Thank you very much. Over to Dr. Parag and Dr. Atul.
I just
I
wanted to
hope
say
everyone-
that, first of all, big shout out to our jury, our participants, and to Dr. Atul. But I think the largest shout out, apart from, of course, Nisha, who's been the backbone, goes out to Dr. Shweta Prabhakar for motivating us. There were times when we would all kind of take it easy, but Dr. Shweta said, no, this is our launch date. We have to send it out. We just hope and look forward that every World Patient Safety Day, we will keep on getting more and more. Next time, we want to take up the number of competitions itself to 5. We always have support from CAHO, and we hope that you will learn and in small measure, keep growing along with CAHO. Dr. Shweta, thank you once again on behalf of everybody who worked very honestly under your leadership. And we crown you the leader of the entire WPSD competitions. Thank you very much once again. Dr. Atul will agree with me. I think
Shweta's done a wonderful job, and Nisha also done a wonderful job. And
absolutely.
basically, you also been deeply involved in this matter.
Yeah.
I mean, I've been listening on and off, since morning, but It was a treat to listen to few people. And
We had fun.
We had fun.
Dr. Atul sir, thanks to your sponsorship, but I think Dr. Shweta and I had a load of fun throughout this quiz, and I'm sure that our judges in the other two competitions also participated. Dr. Shweta, that's it from our side. We can hand
Yes,
it over back
thank you.
to
Yeah, thank
back
you
to
very
the
much.
chair.
Bye-bye. Thank you.
Thank you, Dr. Aparna.
Bye-bye.
Over to you.
Shweta, well done once again.
Thank you, Dr. Atul. Thank you, Dr. Parag.
Thank you.
Thank you. Dr. Aparna?
So,
I think it's over to Dr. Vinita Kothari for the vote of thanks.
So it was one of the most interesting, exciting, and amazing session we had today. All the topics from effective communication to missed or delayed diagnosis to a unique patient engagement and patient safety. Everything was, we cannot say which was the best. Everything was amazing. My sincere appreciation to all the speakers and moderators. And a big congratulations to all the winners and big appreciation to all the jury members for such a hard work and such an encouraging session. Thank you so much. Thank you.
I think we can call the day to an end. Thank you very much, everybody.
Yeah,
Thank you, everyone.
Yeah.